We're diving into the principles of child growth and development, and our mission for this deep dive is not just to, rattle off a list of clinical milestones or run through a textbook checklist.
No, absolutely not.
Our goal here is to decode the incredibly complex, somewhat messy, but entirely predictable blueprint of how a human being actually grows up.
Because when you look at a child, you have to remember you are not just looking at a miniature adult. You're looking at a system that is actively constructing itself in real time.
Physically, cognitively, socially, all of it.
Exactly. But, there is a brilliant underlying architecture to it all. As pediatric nursing professors, we treat the chapter's learning objectives kind of like a mandatory roadmap. And understanding that architecture is step one.
Oh, I promise you, if you are listening to this, by the end of our conversation, you are going to completely rethink a toddler's temple tantrum. You'll understand why 5-year-olds seem to be, like, all tonsils, and you'll discover why a simple game of peekaboo is actually this massive neurological triumph.
It really is.
Okay, let's unpack this, because we have to start with the physical foundation before we can get to the mind, right?
We do. Because before we can begin to understand how a child processes reality, we really have to understand how their physical hardware is built. Clinically speaking, at the bedside, we need to draw a hard line between two terms that people use interchangeably all the time.
Growth and development.
Yes, but they are fundamentally different. Growth is purely quantitative. It is a literal increase in physical size. So when you see a pediatric nurse measuring height, weight, or head circumference and plotting it on a chart, that is growth.
Right, it's numbers.
Development, on the other hand, is qualitative. It refers to maturation, so an increase in skill or the ability to function.
So growth is like adding more bricks to the house, but development is wiring the electricity and setting up the plumbing so the house actually works.
That's a great way to put it.
And looking at the textbook, this process isn't random. It follows some very specific physical directions, starting with the cephalocaudal pattern. And, checking off our contextualized vocabulary here, cephalo means head and caudal means tail.
Which means physical maturation proceeds from the head downward. And this is the underlying mechanism for why a newborn gains the ability to lift their heavy head long before they have the core strength to sit up. And, they can sit up long before they have the motor control in their legs to walk. The neurological control is literally moving down the spinal cord.
It makes me think of building a skyscraper. You absolutely have to secure the foundation and the ground floor in this case, head and neck control, before you can start building the penthouse up top.
Exactly. And that pairs perfectly with the second pattern, which is proximal to distal. That means development moves from the center of the body outward to the extremities.
So proximal being close to the center, distal being far away.
Right. And that is why you'll see a 4-month-old infant clumsily swiping their entire arm at a dangling toy. The gross motor control in their shoulder and torso is online, but the fine motor control hasn't reached those distal endpoints yet.
The fingertips.
Right. It takes until they are about 10 months old before they can use a pincer grasp to pick up, like, a single tiny piece of cereal.
But let me push back on this idea of it being a smooth, uniform process for a second. Because when you look at a growth chart, it kind of implies this steady, linear leveling up. Like a child is just getting 10% bigger and stronger across the board every year.
Right, but human tissue growth is actually incredibly chaotic.
Wait, really?
Yeah, it is highly asymmetrical. Different tissues in the body are on completely different biological clocks. Neurologic tissue. So the brain and the nervous system grows at an astonishing rate.
Wow.
It actually reaches its mature proportions by age 2 to 5.
That's wild. So a 5-year-old essentially has an adult-sized brain packed into that tiny skull.
Yeah, which perfectly explains why their heads look disproportionately large.
Right.
But contrast that with lymphoid tissue, which makes up the immune system. That tissue peaks very early in childhood to provide rapid protection against all the novel bacteria and viruses a young child encounters.
Which leads to a really fascinating pediatric clinical quirk. If you look in the back of a healthy 5-year-old's throat, they appear to be, well, just all tonsils.
Absolutely.
Yeah.
And furthermore, a pediatric nurse can often easily palpate or feel a 5-year-old's spleen through their abdomen.
Which is a massive red flag in an adult, right? Like, if a doctor can feel your spleen from the outside, they are immediately ordering tests because they're worried about a serious infection or disease or a rupture.
Exactly. It's a major nurse-first priority in adults. But in a kindergartner, that palpable spleen is just a normal sign of a robust, hyperactive immune system doing exactly what it's supposed to do.
Wow.
Meanwhile, genital tissue shows almost no growth at all. until the hormones of puberty kick in. So you have a brain that's fully sized by age 5, an immune system that is in overdrive, and reproductive organs that are dormant.
Okay, so if that is the physical hardware taking shape, we really need to talk about the unique operating system each child boots up with. And in pediatric nursing, that brings us to the concept of temperament.
Yes. Temperament is an individual's inborn reaction pattern. It's their characteristic manner of thinking, behaving, or reacting to environmental stimuli.
And Chess and Thomas, two pioneering researchers, mapped this out, right?
They did. They identified 9 characteristics. We're looking at things like activity level, rhythmicity, which is the predictability of biological functions like hunger and sleep, adaptability to change, and intensity of reaction.
And if you're listening to this and thinking about a stubborn child in your life, it is crucial to note that parents do not cause this. It is entirely how the child arrives out of the box.
Entirely.
And based on those 9 traits, the textbook divides children into categories. You have the easy child, the slow to warm up child, and then about 10% of kids fall into the category clinically labeled the difficult child. Now, labeling a newborn as difficult feels incredibly harsh. Are we saying 1 in 10 kids is fundamentally broken or bad?
Not at all. And what's fascinating here is that that's a huge misconception. In this clinical context, the label has nothing to do with a child being bad or having a behavioral disorder. There are no negative or positive qualities in temperament itself. A child in the difficult category simply has highly irregular daily habits, an intense reaction to stimuli, and a tendency to withdraw from new situations.
So they feel things very loudly, and they biologically fight against rigid schedules. I imagine a highly intense, dramatic toddler might channel that exact same temperament into becoming a brilliant, passionate trial lawyer later in life.
That is the perfect way to look at it.
Yeah.
The issue isn't the child's temperament. The issue is the friction between their temperament and their environment.
Right.
And this is where pediatric nurses use a mechanism called anticipatory guidance.
Which is huge in family-centered care.
Exactly. Because if a parent who thrives on strict minute-by-minute routines has a child with 0 biological rhythmicity, there's going to be conflict at every single meal and bedtime.
Right, and the nurse isn't there to fix the child's rhythmicity because you can't. They are there to teach the parents how to adapt the environment. For example, advising the parent to offer, a grazing plate of healthy snacks throughout the afternoon, instead of forcing the toddler to sit at a table for a rigid 6 o'clock dinner when their body simply isn't hungry.
You adjust the environment to create a healthy fit for the child's hardwired operating system. It minimizes psychological distress for everyone.
But since we're talking about the environment shaping the child's potential, we have to look at the broader external inputs. Because a child doesn't grow in a vacuum. We really need to talk about the social determinants of health, and specifically, the textbook's focus on ACE's adverse childhood experiences.
This is perhaps the most critical external factor we look at. ACEs include traumatic events like severe neglect, maltreatment, or bouncing between unstable living situations.
Foster homes, things like that.
Right. For a long time, we viewed these solely as psychological burdens. But the physiological reality is that toxic stress alters the biological blueprint.
Because of the stress hormones, right. If a child is living in an unsafe environment, their body is constantly flooding with cortisol.
Yes. And chronic cortisol exposure keeps the nervous system in a permanent state of fight or flight. Biologically, when a body believes it is under attack, it halts long-term investments.
Wow.
Elevated cortisol literally blunts the release of growth hormone from the pituitary gland. It redirects the body's resources away from building new physical tissue or complex neural pathways and forces all energy into basic survival.
So a child with high ACEs might physically stop growing and fail to hit their developmental milestones simply because their body doesn't feel safe enough to expend the energy on maturation.
Exactly.
That paints such a vivid picture of why emotional safety is a literal biological necessity. And speaking of biological necessities and inputs, we have to discuss the physical fuel required for this growth, nutrition.
I was looking at the section on dietary needs, and I was struck by how crucial fats are for infants. You absolutely do not put a baby on a low-fat diet.
Oh, you cannot, because dietary fat is the building block for myelin.
Myelin is the protective, fatty sheath that wraps around the spinal nerves. It acts like the rubber insulation around an electrical wire, allowing neurological impulses to travel quickly and efficiently. If an infant doesn't get enough fat, That rapid neurological growth we discussed earlier just stalls out.
The brain literally cannot finish wiring itself.
Exactly.
The sources also dig deep into vitamins, separating them by how the body processes them. So you have your fat-soluble vitamins A, D, E, and K, which the body can store and reserve. But the water-soluble ones, like the B-complex vitamins and vitamin C, are flushed out and need daily replenishment.
Which brings up a very practical clinical challenge we face at the bedside. We are seeing a significant rise in families raising children on strict vegetarian or vegan diets.
Right, and if you are cutting out major food groups, how do you ensure the child has the fuel to hit these biological milestones? Like, take vitamin B12, for example. The textbook highlights that B12 is incredibly unique because it is only found naturally in animal products.
It is, so it requires meticulous dietary mapping. If a vegan child does not receive a daily B12 supplement, either through fortified drops or specific foods, they are at high risk for macrocytic anemia.
And macrocytic anemia means the body is producing red blood cells that are abnormally large and structurally immature. They can't carry oxygen properly, which leaves the child profoundly lethargic and can cause irreversible neurological damage. It's a huge red flag.
It is a severe developmental roadblock. And iron is another major hurdle for these diets. Parents might know that dark leafy greens contain iron, but plant-based iron is biochemically much harder for the human digestive tract to absorb compared to the iron found in, say, in a steak.
But there is a fascinating physiological workaround here. Vitamin C acts as a catalyst for plant-based iron absorption. So the clinical advice isn't just, feed your kids spinach. It's to pair that iron-rich food with a vitamin C source at the exact same meal.
Right.
You serve the broccoli with a side of oranges, you squeeze lemon juice over the lentils, it chemically unlocks the fuel.
It's all about optimizing the inputs. Because once the body is properly fueled and the physiological hardware is growing, we start to see the emergence of the mind. This shifts us from physical growth to cognitive development, heavily charted by the Swiss psychologist Jean Piaget.
Piaget is essentially the architect of how we understand a child's concept of reality. He mapped out cognitive development into specific stages, starting with the sensorimotor stage in infancy, where a baby learns entirely through touching, tasting, and basic reflexes.
Right.
But the crown jewel of this stage is the concept of object permanence.
Yes. Object permanence is the cognitive realization that an object or a person continues to exist, even when it is completely out of sight.
Here's where it gets really interesting. Before a baby develops this, their universe is entirely literal. If you put a blanket over a toy block to a 4-month-old, that block hasn't just been hidden. It has ceased to exist in the fabric of reality. That is why the game Peekaboo is an absolute thriller for an 8-month-old. When you cover your face with your hands, you are gone. And when you pull your hands away, you've miraculously materialized from the void.
But once that neurological pathway connects and they master object permanence, Peekaboo loses its magic. They know you are just hiding. And this cognitive leap has a profound behavioral side effect, which is separation anxiety.
Oh, right.
Around 8 to 12 months, a baby will suddenly start screaming when their parent leaves the room. And clinically, we have to reassure parents that it's not because they are regressing. It is because they finally have the cognitive capacity to understand that their parent still exists somewhere else, and they want them back.
They realize the parent is out there in the world without them.
Exactly.
From there, Piaget says, toddlers and preschoolers move into the preoperational stage. And this is the era of magical thinking. The hallmark of this stage is a complete lack of a concept called conservation.
Yes, conservation.
Picture the classic water glass experiment. You sit a preschooler down at a table and show them 2 identical, short, wide glasses filled with the exact same amount of water. You ask, do these have the same amount? The kid says yes.
Right.
Then, right in front of their eyes, you take one of those short glasses and pour the water into a tall, skinny glass. If you ask the preschooler which glass has more water now, they will point to the tall glass every single time.
Even though they just watch the physical transfer of the liquid. They do this because their brain is utilizing a mechanism Piaget called centering. They can only process one single variable at a time.
Interesting.
So they see that the height of the water has increased, and their brain literally cannot simultaneously compute that the width has decreased.
Yeah.
They lack conservation, the understanding that quantity remains constant despite a change in shape.
Now, I have to bring up a pushback that modern researchers and even the textbook raise regarding Piaget. He developed this entire framework in the mid-20th century, heavily relying on observations of his own children.
Right, it's a known limitation.
And today, we have toddlers who are swiping on iPads, navigating interactive puzzle games, processing rapid visual stimuli. Are modern kids progressing through these cognitive stages faster than Piaget's timeline suggests?
It is a vital critique. The environmental inputs have radically changed. Modern digital exposure demands early problem solving, and there is evidence suggesting that children today may reach the capacity for abstract thought slightly earlier because their daily environment requires it.
That makes sense.
However, while the exact timeline might shift by a few months, the sequential mechanism Piaget identified the necessary journey from concrete sensory input to complex abstract reasoning remains universally accurate.
You can't skip the foundational steps. So the child is growing physically, their brain is processing reality cognitively. Next, they have to figure out how to navigate other human beings, which turns us to social navigation, mapped out by Erikson.
Erikson gave us the stages of psychosocial development. And unlike Sigmund Freud, who primarily analyzed psychosexual drives that lead to mental illness, Erikson focused on the social conflicts a person must actively resolve to achieve a healthy mental state.
He maps out the entire lifespan, but focusing on the early years, the very first conflict an infant faces is trust versus mistrust.
When a newborn cries because they are hungry or terrified, they are entirely helpless. If a caregiver consistently responds, feeds them, and comforts them, the infant's brain internalizes a fundamental rule. The world is a safe, predictable place where my needs will be met.
They develop foundational trust.
Exactly. But if the caregiver is neglectful or wildly inconsistent, the infant internalizes mistrust, creating a physiological and psychological guard that can echo through every relationship they have for the rest of their life.
Then they hit the toddler years, and the conflict evolves into autonomy versus shame and doubt. And this brings us back to the temper tantrums I mentioned at the start. When a 2-year-old stubbornly screams, "No," when you try to put on their shoes, and it takes 20 agonizing minutes to get out the door. Are they just being defiant?
It absolutely feels like defiance to an exhausted parent. But developmentally, we have to reframe this. Up until this stage, infants view themselves as physical extensions of their caregivers. During toddlerhood, their brain makes a staggering realization.
That they are a separate person.
Yes, they realize they are a distinct, separate entity with their own physical boundaries and their own will.
So screaming no isn't malice, it's a declaration of independence.
Exactly. They are testing their autonomy. If caregivers constantly scold them for this natural exploration, or if parents impatiently do everything for the child because it is faster, the child fails to resolve the conflict.
Oh, wow.
They leave this developmental stage carrying a deep, lingering sense of shame and doubt in their own capabilities.
The journey just keeps going. Preschoolers face initiative versus guilt. This is why letting a 4-year-old make an absolute mess while finger painting isn't just about fun. It is the mechanism through which they learn to initiate tasks and execute creative ideas without feeling guilty for the chaos.
Right.
Then, school-aged children hit industry versus inferiority. They need to learn how to tie their shoes, complete a spelling test, and feel a sense of practical competence, or they will feel inferior to their peers.
Resolving each of these social conflicts builds the necessary armor and self-esteem required to survive the turbulence of adolescence.
Which brings us to the final hurdle in our deep dive. The physical body is built, the cognitive mind is awake, the social identity is forming. The last piece of the blueprint is the moral compass. How did the child actually learn the difference between right and wrong?
The foundational textbook theory here is Lawrence Kohlberg's stages of moral development. Kohlberg argued that moral reasoning evolves in a specific trajectory. He starts with the pre-conventional stage, typical of young children. At this level, morality is purely pragmatic. A child does the right thing solely to avoid punishment. If a 5-year-old refrains from hitting their brother, it is not because they have a deep, empathetic understanding of human suffering. It is simply because they do not want their iPad taken away.
It is entirely transactional. From there, Kohlberg says they move to the conventional stage.
Correct. As they reach school age, children begin to follow rules because they want to maintain social order and be perceived by authority figures as a good boy or a good girl.
Right.
Finally, Kohlberg points to the post-conventional stage, usually reached in older adolescence or adulthood, where an individual follows an internalized, abstract ethical standard, even if doing so breaks a societal rule.
But the textbook provides a massive asterisk next to Kohlberg's work. His theory is treated as foundational, but it is deeply flawed in its methodology, isn't it?
It is. And if we connect this to the bigger picture, a sociologist named Gilligan provided a brilliant critique of Kohlberg. She pointed out a glaring issue. Kohlberg conducted his foundational research almost exclusively on male subjects.
Hmm.
He built a developmental scale that prioritized what Gilligan called an ethic of justice, a system focused on rigid rules, logic, and individual rights.
And Gilligan argued that because of how society operates, females are often socialized to prioritize an ethic of care. They are taught to focus on relationships, the emotional context of a situation, and minimizing harm to others, rather than strictly adhering to a rigid rule book.
Because Kohlberg's scale was designed to reward the ethic of justice, young girls were frequently scoring lower on his developmental tests.
That's incredibly biased.
Right. They appeared less morally mature on paper, simply because they were factoring the complex social and emotional context into their moral decision-making, which his male-centric scale didn't account for.
So what does this all mean for us? It means that building a human being is infinitely more complex than plotting height on a chart. A child's concept of fairness, their cognitive abilities, and their social resilience are deeply tangled up in their biological readiness, the safety of their environment, and the societal expectations placed upon them.
We have to look at the holistic mechanisms of the child, not just the textbook standard.
We have covered incredible ground today. We started with the biological blueprint driving cephalocaudal physical growth and the hardwired, sometimes frustrating quirks of an infant's temperament. We look at how toxic stress and a lack of vitamin-rich fuel can literally halt maturation.
We really went through it all.
We watched the brain unlock the magic of object permanence with Piaget, navigated the vital social battlegrounds of toddler autonomy with Erikson, and finally explored the complex construction of a moral compass with Kohlberg and Gilligan.
It is a phenomenal, interconnected trajectory, and I want to leave you with one final thought to ponder after everything we've unpacked today.
Lay it on us.
If so much of our foundational development, our inborn temperament, the literal rapid growth of our neurologic tissue, and our deep-seated sense of trust or mistrust is effectively locked in during those first few years of life, how much of our adult personality is actually a conscious daily choice? And how much of it is just the echo of our toddler selves, still stubbornly trying to master our own autonomy in a world we are just trying to understand?
Wow, that is exactly the kind of question that will keep you staring at the ceiling tonight. Thank you for joining us on this deep dive. Keep questioning the incredible mechanisms of the world around you, and we will see you next time. Picture this clinical scenario. A 19-year-old parent walks into your pediatric clinic carrying their 2-month-old infant, and they just look completely defeated.
Oh, yeah. Massive dark circles under the eyes, right?
Exactly. And they tell you, the baby cries every single evening for hours. I am just so exhausted. They say they've tried absolutely everything.
Let me guess. They stopped breastfeeding and switched to formula.
Yep. Switched to formula, and they even started adding rice cereal to the bottle, hoping the heavier food would help the baby sleep.
Oh, boy.
Right. But nothing works. The baby is just pulling their little legs up to their chest, screaming. So what is actually going on here?
Well, it is the classic presentation of a highly stressed family unit. And as a pediatric nurse, when you step into that clinic room, you are walking right into the middle of a very delicate, complex dynamic.
Because the baby's symptoms and the parent's exhaustion are, completely intertwined.
Exactly. They don't exist separately.
So, today on this deep dive, we are looking at the 365 days of absolute chaos and physical metamorphosis that happens in the first year of life.
That's a wild ride.
It really is. And for you, the nursing student listening right now, our goal today isn't just to help you memorize some list of vital signs or milestones. We want you to achieve absolute mastery of the material.
Right, because we're treating Chapter 29 as our mandatory roadmap today.
Exactly. We're going to track the vital signs of different developmental stages, clinically contextualize your pediatric vocabulary, and, crucially, identify the subtle red flags that require immediate action at the bedside.
Because it truly is a critical period. The physical and cognitive transformation an infant undergoes from 1 month to 1 year it's unmatched by any other stage of human development.
But before we even put a stethoscope on that screaming 2-month-old, we have to look at the bigger picture.
Foundational goals.
Right. Because if the first year of life is essentially building the foundation of a skyscraper, it seems like a huge portion of our nursing care actually has to focus on the construction crew.
Meaning the parents.
Yeah, rather than just the building itself. Is that accurate?
That is the core philosophy of pediatric nursing. It is entirely family-centered. A child does not exist in a vacuum.
Right.
Treating that 19-year-old parent's sleep deprivation, assessing their coping skills, providing education that is quite literally just as vital as treating the infant. You simply cannot have a healthy baby without a supported caregiver.
Which brings us to the overarching national goals we are trying to achieve in pediatric healthcare, right? The Healthy People 2030 initiatives.
Yes, we formulate our actual bedside nursing diagnoses based on these big national targets.
So what are those specific targets for infancy?
Well, as nurses, we are advocating to help the nation achieve a few very specific statistical targets. First, we want to increase the proportion of infants who are exclusively breastfed through their first 6 months.
With the goal of having, what, 54.1% of infants still receiving some breast milk at 1 year of age?
You got it, 54.1%.
Because the immune benefits and the GI maturation that breast milk provides are just so crucial during that window.
Precisely. And the second major target is aiming for 88.9% of infants being placed exclusively on their backs to sleep.
Ah, the famous Back to Sleep campaign.
Right. Designed to prevent sudden infant death syndrome, or SIDs. And third, we are working to reduce infant deaths related to congenital anomalies.
Okay, so these national targets directly shape our nursing diagnoses.
They do.
When you are formulating a care plan for an infant, your diagnosis isn't just focused on the baby, like risk for infection.
No. A huge part of the care plan includes diagnoses like sleep deprivation related to providing infant care.
Or ineffective role performance.
Exactly. We are actively planning interventions for the parents based on these goals.
Oh, wait, I want to pause on the Back to Sleep campaign for a second. We know that placing a baby on their back to sleep creates a very specific physical outcome, right? Occipital asymmetry.
Yeah, the flattening of the back of the skull.
So we are actively prescribing a practice that we know causes a physical skull deformity. How is that not just, trading one massive problem for another?
Well, it sounds counterintuitive, I know. But you have to look at the severity of the trade-off here.
Okay.
We place babies on their backs because it actively prevents fatal airway obstruction and suffocation. SIDS is lethal.
Right, of course.
The flattened head, the occipital asymmetry, is largely a cosmetic issue. And more importantly, it's entirely correctable.
Oh, this is where the nursing intervention comes in. Tummy time.
Exactly.
Hmm.
We teach parents to implement supervised tummy time while the infant is awake. But you don't just tell a parent, put the baby on their stomach during the day.
You have to explain the why.
Always.
Yeah.
You explain that tummy time relieves the pressure on the skull and strengthens the neck muscles so the baby can eventually roll over. Once they understand the mechanism, that daily routine becomes an active therapy they're actually invested in.
Okay, that makes perfect sense. So the foundational goals are set. Now let's look at the actual physical machine of the infant as it undergoes this rapid growth.
Oh, the growth is incredible.
Yeah, the sheer math of infant weight gain is staggering.
It really is. In general, an infant's birth weight doubles by 4 to 6 months of age.
And by 1 year.
It triples. If an infant is born weighing 7 pounds, you are looking at a 21-pound 1-year-old.
That's wild. And their length.
Length increases by 50%, usually growing from around 20 inches at birth to 30 inches at 1 year.
Think about the massive metabolic demand of that kind of growth, which perfectly explains why infant vital signs are so drastically different from adults.
Oh, absolutely.
For you listening, you have to memorize these ranges because a newborn's heart rate is racing at 110 to 160 beats per minute.
But by the end of that first year, it slows down to 100 to 120 beats per minute.
Why is it so fast initially, though?
It comes down to the mechanics of their tiny heart. An infant stroke volume, meaning the actual physical amount of blood the heart can pump with a single beat, is just minuscule.
Okay.
But because they are growing so rapidly, their bodies are burning energy like a furnace. They're demanding massive amounts of oxygen.
So since the heart can't pump more blood per beat, the only way to meet that metabolic demand is to pump faster.
Exactly. And their respiratory rate follows the exact same logic. It drops from a rapid 30 to 60 breaths per minute at birth down to 20 to 30 breaths per minute by year 1.
So when you, the nursing student, are standing at the bedside evaluating a monitor, you have to know these age-specific parameters.
You really do.
Because a respiratory rate of 50 in a 1-year-old is a massive pediatric red flag indicating severe respiratory distress.
But in a 1-week-old newborn, you wouldn't even blink at it.
Right. Speaking of vital signs and red flags, we have to talk about fluid balance.
Yes, this is arguably one of the most critical concepts for a bedside pediatric nurse to grasp.
Walk us through it.
So an infant's extracellular fluid, that's the fluid sitting outside their cells, in their blood and tissue spaces, accounts for 35% of their total body weight.
35%. And in an adult?
In an adult, that number is only 20%.
Wow. How does that shift the way we assess a sick infant?
Well, it makes them incredibly fragile when it comes to fluid loss.
Mm-hmm.
Because so much of their fluid is extracellular, and because they have a massive body surface area relative to their weight, they lose moisture incredibly fast through their skin and their rapid breathing.
So if an infant catches a standard GI bug and starts vomiting or having diarrhea.
They aren't just uncomfortable. They are draining that 35% extracellular reserve almost instantly.
Yeah.
They can go into life-threatening hypovolemic shock in a matter of hours.
So rapid, life-threatening dehydration is always at the top of your mind.
Always.
Let's shift to their digestive tract, which brings up a really important piece of clinical vocabulary, the extrusion reflex.
Ah, yes. The extrusion reflex is an automatic, involuntary response where a baby thrusts their tongue forward and out of their mouth whenever any solid object or food is placed on it.
It's like a built-in protective mechanism to prevent choking, right?
Exactly, and it naturally fades away around 3 to 4 months of age.
Which brings us right back to our opening scenario with the 19-year-old parent. They were trying to feed rice cereal to a 2-month-old.
Right, and the baby keeps pushing the food out with their tongue.
Mm-hmm.
The parent gets frustrated thinking, oh, my baby is just a picky eater. They hate this cereal.
As the nurse, you have to reframe that for them.
You do. It's not a preference. It's an involuntary reflex screaming that their digestive tract is not ready for solids.
So if their liver and kidneys aren't fully online yet, it sounds like putting heavy, unrefined fuel into a brand new car engine that hasn't been properly broken in yet.
That is a great analogy. An infant's liver is highly immature, meaning it cannot conjugate drugs or process toxins efficiently.
And their kidneys.
Also immature. Terrible at concentrating urine or eliminating waste. And to your point about the heavy fuel, infants completely lack the digestive enzyme amylase until they're about 3 months old.
And amylase is what breaks down complex carbohydrates.
Exactly. So giving rice cereal to a 2-month-old doesn't just fail to help them sleep. Their body literally lacks the chemical tools to digest it. It just sits there, causing cramps and gas.
Ouch. We also see an interesting shift in their blood around 2 to 3 months, right? A condition called physiologic anemia. Why does their iron suddenly drop?
It's a fascinating transition phase. The red blood cells an infant is born with the fetal, red blood cells have a very short lifespan. They only live for about 4 months.
Okay, so around 2 to 3 months of age.
You have this massive die-off of fetal cells.
Yeah.
But the infant's own bone marrow hasn't quite ramped up its production of adult hemoglobin to replace them yet.
Ah, so you see this natural temporary dip in iron levels.
Ex-
All of this intense internal maturation directly fuels their outward physical abilities. Because that internal engine is maturing so fast, it immediately starts showing up in how the baby moves.
Definitely. Let's look at their motor and cognitive milestones.
Physical development in an infant is always cephalocaudal, right?
Yes.
Yeah.
That means it progresses from the head downward to the toes. They gain control of their heavy head long before they gain control of their legs.
Right. So at 2 months, they develop the neck strength to lift their head.
And by 4 months, they can roll from their front to their back.
And they roll front to back first simply because their head is so heavy, it throws them off balance and just kind of carries their body over.
Yeah, pretty much. Then we hit 8 months. 8 months is a massive, highly testable milestone to assess.
Sitting securely without support?
Yes. If you are assessing an 8-month-old and they cannot sit independently without toppling over, that is a red flag that warrants further neurologic evaluation.
Then the mobility really takes off. At 10 months, they can pull themselves up to a standing position.
At 11 months, they start cruising.
Cruising, meaning walking sideways while holding onto the edge of a couch or coffee table.
All right, and then we get to the actual independent steps,
Yeah.
which happen anywhere from 12 to 22 months.
Wait, a parent usually expects their kid to be walking on their first birthday, but they technically have until nearly their second birthday.
Yep.
That is almost a year of potential panic for a parent.
Which is exactly why anticipatory guidance is a cornerstone of pediatric nursing. You cannot wait until the child is 1 year old to start talking about walking.
Because if you wait, the parent will spend 3 months agonizing that their child is delayed.
Exactly. At the 9-month well-child visit, you tell the parents, your baby might take their first steps at 12 months, or they might wait until 20 months, and both timelines are completely 100% normal.
You set the expectation early to inoculate them against that anxiety.
You have to.
We also see a terrifying convergence of milestones around 10 months. They develop the pincer grasp.
Right, the ability to use their thumb and index finger to pick up tiny objects.
But they also develop object permanence.
Yes, object permanence is the cognitive realization that things out of sight still exist. Before this, if you hid a toy behind your back, the baby thought it ceased to exist.
Now they know it's there.
Yeah.
This is why peekaboo suddenly becomes the most hilarious, thrilling game in the world to a 10-month-old.
It blows their mind.
But the clinical relevance here is what keeps nurses and parents awake at night. You combine the ability to pick up tiny objects with a drive to hunt for things that are out of sight.
And suddenly every coin, battery, or piece of dog food under the couch becomes a deadly choking hazard.
Because they will actively go hunting for it, pick it up with that brand new pincer grasp, and immediately put it in their mouths to explore it.
Exactly.
Before we move on from the nervous system, we need to highlight some distinct neurologic red flags. Infants are born with primitive reflexes, but those are supposed to fade, right?
Yes. As the higher brain, the cerebral cortex, matures, it suppresses those primitive automatic reflexes.
Like the Moro reflex.
Right. The Moro reflex, which is that dramatic starter reflex where they throw their arms out, should be completely gone by 6 months.
And if an infant still has a Moro reflex at 7 or 8 months?
It indicates underlying neurologic disease because the higher brain isn't taking over.
What about fisting of the hands?
If an infant is still fisting their hands tightly past 5 months, that suggests a motor delay or even hemiparesis.
And their eyes.
If an infant's eyes are consistently crossing past 3 months, they require a specialized ophthalmology evaluation to prevent permanent vision issues.
Okay, so as their brain develops object permanence, they don't just realize that hidden toys still exist. They also begin to profoundly understand who is permanent in their lives.
That's a huge shift.
And this completely shifts how we have to approach their emotional care at the bedside.
We rely heavily on Erikson's stages of psychosocial development to understand this. For the infant, the foundational stage of their entire personality is trust versus mistrust.
And trust isn't built by a rigid military-style feeding schedule.
No, it is built by predictable routines and a core, consistent group of caregivers responding reliably to their cries and needs.
We see that first real social connection early on, right at 2 months, with the social smile.
Yes, it's not just a grimace from gas. It's a genuine, engaging reaction to a human face.
But then we hit 8 months, and we see the dreaded 8th-month anxiety.
Better known as stranger anxiety. The clinical relevance for you at the bedside is huge here. An 8-month-old will absolutely not go willingly into your arms.
If you just walk into the hospital room, smile, and reach for them,
They will immediately scream and cling to their parent.
So stranger anxiety isn't an emotional regression, it's actually a massive cognitive upgrade.
Exactly.
It's like they just installed a mental security system to differentiate friend from foe.
That's exactly what it is. They finally have the cognitive ability to recognize exactly who their trusted, life-sustaining people are. By default, that means everyone else, including the nice nurse and the scrubs, is a potential threat to their safety.
So how does that impact our delivery of atraumatic care? Because as nurses, we often have to do painful or scary things to infants in the hospital, like starting IVs or giving injections.
Well, atraumatic care is all about minimizing psychological and physical distress. First and foremost, you never, ever ask a parent or caregiver to hold down or restrain their child for a painful procedure.
Never.
The parent's role must remain exclusively as the comforter and the safe haven. If you need someone to hold an infant still for an IV, you grab another nurse or a tech to do the safe restraint.
While the parent stays near the baby's face, soothing them.
Exactly.
When you are practicing at the bedside, there are so many small strategies to reduce trauma. You use non-allergenic tape to reduce painful skin tearing.
You warm up your irrigation solutions so you don't shock their system with freezing cold fluid.
And if the baby is NPO, meaning nothing by mouth before a procedure, you provide a pacifier so they can still get the self-soothing benefits of non-nutritive sucking.
And critically, you never mix medication into a baby's primary feeding bottle.
Why is that so important?
Because if that medicine makes the formula taste bitter or strange, the infant won't finish the bottle, meaning they don't get the full dose of the drug.
Oh, and worse, if you ruin their trust in their primary food source, they might refuse the bottle entirely later on.
And you've just created a massive dehydration risk.
Wow. Okay, so with this new mobility, The drive to put everything in their mouths and this deep need for trust, keeping an infant nourished and safe is just the ultimate challenge.
It is exhausting for parents.
Let's look at nutrition, dental care, and some common parental concerns. Let's start with some dental vocabulary.
Okay, so natal or neonatal teeth are teeth that are actually present at birth or erupt shortly after.
And those are often loose, poorly formed, and might need to be removed by a dentist so the infant doesn't accidentally aspirate them, right?
Exactly. Then you have deciduous teeth, which are what we think of as standard baby teeth. Those typically start erupting right around 6 months of age.
Which introduces a major clinical issue we frequently see: baby bottle syndrome or bottle rot.
This is a severe, highly painful form of tooth decay. It's caused by propping a bottle of milk or juice in the crib with the baby at night.
The liquid just pools around the upper teeth while the baby sleeps, and the sugars literally eat the enamel away over time.
It's awful.
I hear this and I immediately want to push back. I get the mechanism, the sugar pools, the enamel rots, plus there is an aspiration risk if they choke on the fluid while flat on their back.
Right.
But if we are constantly educating parents on these dangers, why do we see it so often? At some point, doesn't it cross the line from a mistake into just parental negligence?
It is incredibly easy to jump to judgment when you see a child in pain. But think back to that nursing diagnosis we formulated at the very beginning.
Parental sleep deprivation.
Almost every single case of bottle propping stems from sheer mind-numbing exhaustion or a fundamental lack of understanding about infant biology.
So they're just desperate for sleep.
These parents are so desperate for just 2 consecutive hours of sleep, and they mistakenly believe that a larger continuous source of milk will keep the baby asleep longer. As a nurse, you must approach this with deep empathy.
It goes right back to anticipatory guidance, teaching them about safe sleep habits and realistic infant caloric needs before they reach that breaking point of exhaustion.
Exactly.
Let's get into those nutritional needs. The rule is human milk or iron-fortified formula exclusively for the first 6 months.
And right at 6 months, you introduce iron and zinc-rich complementary foods like pureed meats or fortified cereals.
Why at 6 months? Because remember that physiologic anemia we discussed. By 6 months, the infant's natural iron stores from birth are completely depleted, so they need an outside source.
And there are strict prohibitions. Avoid honey entirely for the first year.
Due to the risk of infant botulism, which their immune system cannot fight off.
Right. And no regular cow's milk before 12 months, because the protein complex is too difficult for their immature kidneys to process.
Plus, it can actually cause microbleeds in their GI tract, worsening that iron deficiency.
Exactly.
And we have to avoid choking hazards. Which brings us to the famous toilet paper rule.
I love this rule. This is a fantastic visual assessment tool for parents. If a toy, a block, or a piece of food can fit completely inside an empty toilet paper roll, it is small enough to lodge in an infant's airway.
And anatomically, an infant's airway is incredibly narrow, roughly the diameter of a drinking straw or a pinky finger.
So foods that are small, firm, and perfectly circular, like hot dogs, whole grapes, or hard candies.
They essentially act as a perfect airtight plug in that tiny airway. Absolutely none of those should be given.
None.
We also need to address how parents interpret pediatric red flags, because parents constantly attribute every single symptom an infant has to teething.
Oh, all the time. Now, teething certainly causes some mild discomfort. It can cause a little irritability, some extra drooling, and a mild decrease in appetite. A high fever, vomiting, profuse diarrhea, or pulling frantically at the ears are never normal signs of teething.
Parents will say, oh, he's just teething.
But as a nurse, you know those symptoms demand priority action because they usually indicate a systemic infection, like an ear infection or a GI virus.
What about spitting up? Because literally all babies spit up. How do you distinguish normal from a red flag?
Spitting up milk that casually rolls down the baby's chin or onto their bib is completely normal.
Okay.
But if you have a 2 to 8 week old infant who is forcefully projecting their vomit 3 to 4 feet across the room, what we call true projectile vomiting, that is a massive red flag.
It points to pyloric stenosis, right?
Yes, which is a physical thickening and blockage of the stomach valve that requires immediate surgical intervention, not just a change in formula.
Okay, let's pull all of this pathophysiology, vocabulary, and family-centered care together into an interprofessional care map.
Let's do it.
Let's go all the way back to our opening scenario. That exhausted 19-year-old parent and the 2-month-old infant who is pulling their legs up and screaming for hours every night.
Based on the timeline and the symptoms, the clinical diagnosis for that infant is likely colic.
And colic is defined by the rule of threes, right?
Yes. It is paroxysmal abdominal pain and intense crying in an infant under 3 months of age, lasting for more than 3 hours a day, for at least 3 days a week.
The baby often has a flushed face, clenched fists, and pulls their legs up tightly to a tense abdomen.
So how does the bedside nurse use the care map to actually solve this?
Well, first, you assess the infant's entire daily routine. What is the parent's feeding technique? Are they using a nipple flow that is too fast, causing the baby to swallow massive amounts of air?
You partner with the primary care provider to conduct a thorough physical exam to ensure there is no hidden physical danger.
Like a strangulated hernia or an undiagnosed infection.
Right. And once physical danger is completely ruled out, you lean heavily into your family-centered care interventions.
You look that exhausted parent in the eye and reassure them. Your baby's crying is not a reflection of bad parenting. You are doing a good job.
And you suggest non-pharmacological soothing interventions, like offering a pacifier, using rhythmic rocking, or taking the baby for a car ride to simulate the movement of the womb.
And you must plan a follow-up. You evaluate not just whether the infant is sleeping better, but whether the parent's coping skills have improved.
So when we strip it all down, the primary nursing intervention for a baby with colic isn't necessarily just fix the baby's stomach.
No, the primary intervention is actually support the family's coping mechanisms.
Precisely. Because if the parent's nervous system is regulated and calm, they have the capacity to co-regulate the infant. When you treat the infant, you are always treating the entire family unit.
That brings us to the end of our journey through the first year of life. You, the nursing student, have just explored the vital signs, the dangerous red flags, and the clinical rationale from a reflex-driven 1-month-old all the way to a cruising, babbling, solid-eating 1-year-old.
So our mission today is a comprehensive, high-yield study review of toddler growth and development. But we're tossing out the dry table of contents. Today's goal is absolute mastery of Chapter 30. We have this strict learning objective roadmap, and we're going to systematically check off all 8 objectives and dissect 7 key vocabulary terms.
But we're looking at them entirely through a pediatric clinical lens. We're going to cover every major milestone, every critical vital sign shift, and those really subtle pediatric red flags.
Right, because passing the test is just step 1.
Exactly.
Yeah.
More importantly, we're going to look at the why behind them. Because when that 2-year-old is screaming at you, knowing the underlying physiology and psychology is, well, it's the only way you're going to successfully provide care.
Okay, let's unpack this. Because
Yeah.
we were talking about that magical and honestly sometimes terrifying window from age 1 to 3. We're watching a stationary, completely dependent infant transform into this, like walking, talking, highly opinionated little scientist.
Highly opinionated is right.
Yeah. And before we can even begin to formulate nursing care plans, we have to establish the physiological baseline. So looking at learning objective 1 and part of 4, assessing normal growth and milestones, how does a toddler physically diverge from an infant?
Well, the physical contrast is actually incredibly stark when you look at the biology. Because during the infant year, growth is explosive, right? It's all about rapid expansion.
Right.
But as a child crosses that 1-year mark and enters the toddler years, that somatic growth slows dramatically. I mean, they only gain about 5 to 6 pounds and grow about 5 inches a year.
Wow, that is a huge drop-off.
It really is. And you'll also see that classic subcutaneous baby fat begin to disappear toward the end of their 2nd year.
I always found that shift fascinating. During infancy, it's almost like their body is focusing all its energy on rapidly expanding like a water balloon, just building raw mass.
That's a great analogy.
Yeah, and then as a toddler, they start rerouting all that metabolic power away from raw growth and into building a leaner, more muscular little engine.
That is precisely the mechanism at work. And because their body is now operating as a leaner, more muscular machine, their hemodynamics, their vital signs, they have to shift to support that new architecture.
Okay, so what do those numbers look like?
So the heart rate drops from those high infant numbers of, around 120 down to 90 to 110 beats per minute. Meanwhile, their blood pressure increases to roughly 99/64 millimeters of mercury.
Let's break down the why there for our listeners, because it's not just random numbers changing. Why does the blood pressure go up while the heart rate drops?
Well, it comes down to vascular resistance and muscle hypertrophy. As the toddler grows taller, their vascular bed lengthens,
Right.
and longer blood vessels create more systemic vascular resistance, which naturally drives the blood pressure up.
Makes sense.
And at the same time, the heart muscle itself is getting stronger. So a stronger heart can pump more blood volume with every single stroke, which means it doesn't need to beat as incredibly fast as an infant's heart to maintain the same cardiac output.
Right, becomes a more efficient engine. And speaking of physical shifts, we also see a major change in their proportions.
We do.
By age 2, their chest circumference finally surpasses their head circumference. The brain has developed to about 90% of its adult size, so the head growth slows, and the chest cavity expands to accommodate those growing lungs. Which actually brings us to a specific piece of clinical vocabulary.
Yes, let's get into the vocabulary.
Because as their body changes, their posture becomes highly unique. The term is lordosis.
Yes, lordosis. This is a completely normal forward curve of the spine at the sacral area, right at the lower back.
And what's the clinical relevance or the mechanism behind that? Because when you see a toddler waddling down the hospital hallway, they look a bit like a tiny pouchy penguin.
They do. It's all about physics and center of gravity.
Mm.
A toddler still has a relatively heavy upper body and very weak abdominal muscles compared to an older child. So to keep from falling flat on their face, the spine has to compensate by curving forward at the lower back to shift their center of mass right over their legs.
Okay, so it's a balancing act.
Exactly. And when you combine that spinal curve with the weak abdominal wall, you get that classic, prominent, pouchy toddler abdomen. And they plant their feet wide apart just to maintain stability, creating that waddling gait.
So it's perfectly normal biomechanics for their developmental stage. But as nurses, while we look at what's normal, we are primarily hunting for what is abnormal.
Absolutely.
And this is tricky, right? Because toddlers are notoriously terrible historians.
Mhm.
They don't have the vocabulary to look at you and clearly articulate their symptoms.
No, they cannot tell you, excuse me, my throat is sore and I feel nauseated.
Right.
This is where we really have to rely on pediatric red flags, those subtle signs of illness that require priority, nurse-first action.
So what are we looking for?
Well, if a toddler has a sudden, complete refusal to eat, or if they're whining in a way that is entirely out of their normal routine, you cannot just write that off as a bad mood.
Because they can't tell you otherwise.
Right. In the absence of words, a sudden change in eating or behavior is the clinical equivalent of them telling you they are nauseated or experiencing some kind of systemic illness.
We also have to watch how they move. I've seen nurses assume a toddler who's limping just took a clumsy fall on the playground. But a limp, or a toddler guarding a swollen joint and refusing to bear weight, that's a massive priority red flag, isn't it?
Oh, absolutely. You must have a high index of suspicion for osteomyelitis.
Which is a bone infection, right?
Yes, it's a severe bacterial bone infection that occurs with alarming frequency in this age group. And the Y is directly tied to their physical growth.
How so?
Because their bones are still growing, the blood vessels form these tight hairpin turns right near the growth plates.
Oh, wow.
Yeah, and blood flow becomes sluggish in those tight turns, which creates the perfect environment for any circulating bacteria to just settle, multiply, and form a deep bone infection. So a limp is never just a limp until osteomyelitis is firmly ruled out.
That is such a critical mechanism to understand.
Right.
And we see similar anatomical vulnerabilities with their respiratory system, right?
Yeah.
Toddlers get a staggering 10 to 12 upper respiratory infections a year.
Yes, their immune systems are still very naive, so they just catch everything. But the clinical red flag here is when a standard runny nose upper respiratory infection suddenly escalates with a high fever, and the child starts aggressively pulling or batting or rubbing at the side of their head.
Oh, right.
That signals otitis media, a middle ear infection.
And again, anatomy is the culprit here, right?
Precisely. In a toddler, the eustachian tube, which connects the back of the throat to the middle ear, is much shorter and lies much more horizontally than in an adult.
Okay, so it's a straight shot.
Exactly. So when they have a throat infection, that bacteria essentially have a straight, flat highway directly into the middle ear. It requires immediate medical evaluation and often antibiotics to prevent pressure buildup and permanent hearing damage.
Wow. Okay, so now that we understand how their physical architecture is changing, we have to look at what's happening inside that 90% grown brain. Moving through objective 4, because as their physical growth slows down, their metabolic energy is aggressively redirected into cognitive and psychosocial development,
Right.
which perfectly explains the behavioral chaos that parents find so deeply exhausting.
What's fascinating here is that you really have to view a toddler as a visitor from a foreign land.
I love that.
Yeah, I mean, they want to participate in everything the family is doing. They want to interact with the environment, but they don't know the customs, the rules, or the language yet. They're desperately trying to figure out how they fit into the world, and they do it entirely through trial and error.
And that biological drive to figure things out brings us to our next major clinical concept,
Yes.
autonomy. In Erikson's stages of psychosocial development, the toddler has entered the stage of autonomy versus shame and doubt. Up until now, they viewed themselves almost as like an extension of their caregivers. But now, their brain is literally hardwiring them to separate, to become an individual. And at the bedside, the clinical manifestation of autonomy is that their absolute favorite word is no.
It is their default setting. No is how they test their boundaries and assert that they are a separate entity from you. But it's not the only cognitive quirk we have to navigate. We also have to understand Piaget's concept of pre-operational thought.
This is where their logic is so entirely different from ours.
Right. In this cognitive stage, children are highly egocentric and they lack mature logic. They cannot change their thoughts to fit a situation, so they try to physically change the situation to fit their thoughts.
Can you give an example of that?
Sure. For example, if you hand a toddler a toy hammer, they don't logically deduce, oh, this is shaped for pounding a nail, because
Okay.
they understand the world through basic sensory action. They might just shake it to see if it rattles or put it in their mouth. That is how they process new objects.
That makes total sense. And then we have the concept of deferred imitation. This is their ability to mentally store an action they saw someone else do and then imitate it much later. And finally, there's the behavioral milestone of parallel play.
Parallel play is a massive shift. It means toddlers play beside other children, not with them.
Right.
If you put two toddlers in a pediatric playroom, they might sit completely back to back, one playing with a set of wooden blocks, the other rolling a plastic truck, just completely ignoring each other.
I always have parents ask me if that means their child is antisocial or developmentally delayed.
It's a totally fair question from a parent, but you have to reassure them that it is perfectly normal cognitive development. It goes back to that egocentrism we just talked about.
Oh, because they can't think about the other kid's goals?
Exactly. Their brains do not yet possess the neurological capacity to process someone else's internal state or cooperate toward a shared goal. They're just enjoying the shared environment.
Okay, so how do we, as bedside nurses, take these specific cognitive traits and use them to provide atraumatic care? How do we get our vital signs, administer our medications, and, do our jobs without absolutely terrifying the child?
Yeah.
Let's take deferred imitation.
Right.
Because their brain stores and processes actions by watching. A nurse should never just walk up and put an old stethoscope directly onto a toddler's chest.
Oh, that will guarantee a meltdown. Instead, you use deferred imitation to your advantage. You place a stethoscope on the parent's chest first, or even on the toddler's stuffed animal. You let the toddler observe the action, process that no harm occurred, and realize the object is safe. Then you hand it to them and let them safely imitate the action before you do your assessment.
That's brilliant. And what about combating that fierce drive for autonomy? How do we bypass that automatic no when we have to do something that's mandatory?
This is a golden rule in pediatric nursing. Never, ever ask a yes or no question for a mandatory clinical task.
Because they'll just say no.
Exactly. If you ask, can I take your blood pressure now? Their developmental drive for autonomy literally forces them to say no. And because the task is mandatory, you then have to physically force them to comply, which completely strips them of their autonomy and creates profound medical trauma.
Instead, you offer focused secondary choices.
Yes.
You walk into the room and say, it's time for your blood pressure. Do you want to hold your yellow duck or your blue boat while we do this? You're making the blood pressure a non-negotiable fact, but you are validating their desperate need for autonomy by giving them control over the manner in which it happens.
It works like magic because it aligns with their cognitive framework rather than fighting against it.
Which naturally moves us into the chaos of behavioral management. We're hitting objectives 2, 3, 5, and 6 here. the nursing process and care plans, because understanding this intense drive for autonomy allows us to directly address the most common parental complaints we hear in the hospital and clinic.
Yeah, parents are often completely overwhelmed by the behavioral shifts.
Oh, completely.
So the foundation of formulating our nursing care plans for behavioral management requires us to differentiate between two highly misunderstood concepts: discipline and punishment.
Okay, what's the difference?
Discipline means setting structured rules and boundaries so children clearly know what the expectations are. It is a teaching tool. Punishment, on the other hand, is the specific negative consequence applied when those boundaries are broken.
Clinically, parents constantly ask for advice about timeouts. But I have to admit, as a nurse, sometimes the textbook advice feels impossible to enforce in a chaotic household. Yeah. The evidence-based recommendation is 1 minute per year of age, so 2 minutes for a 2-year-old in a completely non-stimulating environment.
Right.
But parents will say, my kid just screams the entire 2 minutes, it doesn't work.
That is a very common frustration, and it's where we have to explain the psychology behind the intervention. Timeouts should be used as a form of discipline to allow a child's nervous system to self-regulate.
So it's not a punishment.
No, it's not about making them suffer for 2 minutes. It's about breaking the sensory feedback loop of whatever bad behavior they were engaged in. If they are screaming, they aren't self-regulating. But consistency is more important than duration. They have to learn that breaking a boundary immediately results in a temporary loss of environmental stimulation.
This friction between textbook guidance and parental reality also bleeds into toilet training. It feels like every parent is in a rush to get their toddler out of diapers, and they ask us when the child is ready.
And our answer has to be rooted entirely in biology. Toilet training simply cannot happen until the spinal cord has fully myelinated down to the anal level.
Let's explain myelination for you listening, because it is crucial. Think of the nerves connecting the brain to the sphincter, like a bare copper wire. If the brain sends an electrical signal down that bare wire saying, hold it, the signal disperses into the surrounding tissue and never reaches the muscle.
Right.
Myelin is a fatty sheet that coats the nerve. It acts like rubber insulation around that copper wire. Once the nerve is insulated, the signal travels lightning fast straight to the sphincter.
That is a perfect analogy, and a reliable clinical marker that this physiological insulation has reached the lower half of the body is when the child is able to walk independently.
Oh, interesting.
But physical readiness is only half the battle. They also need the cognitive readiness to recognize the sensation of a full bladder and communicate the need to go. If the parent rushes it before that myelin sheath is fully formed, it just leads to frustration and shame.
Okay, I have to push back on another piece of textbook advice here, because this comes up in clinical practice all the time. Tantrums.
Yeah.
If a toddler is having a massive screaming temper tantrum in the middle of a busy hospital hallway, the textbook tells us to advise the parent to safely ignore it. But in the real world, when the charge nurse and 3 doctors are glaring at you, isn't advising a parent to ignore it, essentially promoting bad, disruptive parenting in public. It feels incredibly counterintuitive.
Well, it feels awful in the moment, which is exactly why parents give in. But you have to look at the psychological mechanics of a tantrum. A standard tantrum is a toddler's physiological response to overwhelming frustration when their brain lacks the vocabulary to express big emotions.
Okay.
If a parent gives them even negative attention like yelling, or if they give in to what the toddler wants just to quiet them down, they have essentially rewarded the behavior.
Right. They teach the toddler that screaming is the most effective tool to get a reaction.
Exactly. Safely ignoring the tantrum removes the reward. It starves the behavior of the attention it seeks. It forces the child's brain to realize that throwing themselves on the floor doesn't work, which pushes them to develop more mature, effective coping methods over time.
But as nurses, our job isn't just to validate behavioral milestones. We have to evaluate if it is just a standard behavioral tantrum.
And that is a critical pediatric red flag. You must differentiate a standard behavioral tantrum from seizure activity or from a phenomenon called true breath-holding spells.
True breath-holding is terrifying to witness.
It really is. It is an involuntary neurologic reflex, usually triggered by sudden stress, pain, or frustration. The child will literally halt their breathing after a sharp expiration.
Wow.
It triggers a massive vagal response. Their heart rate plummets, they turn blue or cyanotic, and they completely slump to the floor unconscious.
So they actually pass out.
Yes, and if a child passes out during a tantrum, that is not a behavioral issue to ignore. That is a physiological event that requires immediate medical follow-up to rule out cardiac or neurological anomalies.
That is such a vital distinction for the bedside nurse. And it brings us to a broader concept of safety and vulnerability. Moving to our final objectives, 7 and 8, we've built a solid foundation of normal physical behavior and cognitive quirks. Now, we have to synthesize all of this to care for vulnerable populations. We have to apply the QSN framework.
Yes, and for those who might need a refresher, QSEN stands for Quality and Safety Education for Nurses. It's the gold standard framework we use to prevent medical errors and improve patient outcomes.
And it focuses heavily on things like patient-centered care, teamwork, evidence-based practice, quality improvement, safety, and informatics.
Right, and when we look at the safety competency for toddlers, accidental injury is the absolute highest risk for this age group. I mean, they are highly mobile, but have zero impulse control or risk assessment skills.
So true.
Motor vehicle safety, for instance, dictates that toddlers remain in rear-facing car seats until at least age 2 or until they outgrow the seat's limits.
And we have to explain the physics of why rear-facing is non-negotiable. A toddler's head is disproportionately massive compared to their body, and their neck muscles and spinal ligaments are extremely lax.
Right, they can't support it.
Yeah, so in a forward-facing crash, the heavy head snaps violently forward, which can literally separate the spinal cord. A rear-facing seat absorbs that crash force across the entire back and shell of the seat, protecting that fragile neck.
Exactly. And after they transition, they need a 5-point restraint in the back seat to keep them entirely out of the explosive impact zone of front airbags.
We also have to look past the hospital walls to where these kids live, specifically looking at environmental hazards. I've been seeing a lot of updated guidance on lead poisoning, and it feels like a hidden epidemic.
Lead poisoning is incredibly insidious. It most often stems from microscopic paint dust in houses built before the ban in the late 1970s, particularly homes built before 1950.
And how do they ingest it?
Well, because toddlers are in that sensor-motor stage where they explore the world by putting their hands and objects into their mouths, they inevitably ingest this dust from floors and windowsills.
And the cellular mechanism of how lead destroys a child's brain is terrifying. Can you walk us through how that actually happens?
Biologically, the human body mistakes lead for calcium.
Wait, really?
Yes. And calcium is essential for neurotransmitters to fire in the brain and for bones to grow. When a toddler ingests lead, it sneaks right past the blood-brain barrier because the body thinks it's calcium.
Oh, wow.
But instead of helping neurons fire, the lead blocks the receptors, effectively short-circuiting the developing brain.
And the red flags are so subtle. I mean, lead levels as low as 5 micrograms per deciliter cause permanent cognitive damage, decreased IQ, and behavioral issues. But early on, a child won't look poisoned.
No, they don't.
They just show vague, unexplained irritability, chronic fatigue, and abdominal pain. A pediatric nurse must always screen for the age of the home and these subtle symptoms, because once the neurological damage is done, it cannot be reversed.
Which perfectly illustrates why patient-centered atraumatic care is so vital. And we have to extend that care to the most vulnerable of all, the medically fragile or chronically ill toddler.
This is where the emotional weight of pediatric nursing really hits you.
Ah.
Because how do you promote that vital psychological sense of autonomy in a toddler who is physically challenged, chronically ill, or living in a hospital environment where they essentially have zero control over their own body?
It is a massive challenge. If we connect this back to Erikson, a chronically ill toddler is still fundamentally a toddler. Their brain is still demanding autonomy.
Right.
If the hospital environment completely strips them of that control, if we dictate when they eat, when they sleep, and constantly subject them to painful procedures without input, they will suffer severe psychological regression. They will retreat inward and stop developing. So we have to engineer highly specific bedside interventions to give them power.
Let's walk through a clinical scenario. You have to do a sterile central line dressing change on a terrified 2-year-old. How do you give them control back without compromising the sterile field?
You find ways to make them an active participant rather than a passive victim. Before you start, you tear off a few safe pieces of medical tape and hand them to the toddler.
Oh, I like that.
You tell them, your job is to hold this tape for me until I need it. Suddenly, they aren't just being pinned down. They have a crucial job. They feel involved and in control of a piece of the procedure.
And what about when it comes to medications? Because they hate oral syringes.
You never, ever give them a choice on whether to take the critical medicine. That is a non-negotiable safety issue. But you lean hard into those focused secondary choices we talked about earlier.
Right, the duck or the boat.
Exactly.
Right.
You say, it is time for your medicine. When you are done swallowing, do you want to drink apple juice or ice water? You give them absolute control over the reward.
What about when we actually have to physically restrain them for something like an IV insertion?
You restrain only the specific joint or body part that is absolutely necessary for the procedure and nothing more. If you have to hold their arm, you let them sit up. You let them kick their legs.
So no full swaddling.
No, pinning a toddler down entirely, swaddling them so tightly they cannot move a muscle when they are already terrified, that strips them of their core biological drive for physical autonomy. It is highly traumatic. Every small choice you offer, every inch of movement you allow, is a building block for their cognitive development. It prevents the hospital environment from stunting their growth.
It really is about finding the yes in a world of no for these kids. Every interaction is an opportunity to either build their trust or deepen their trauma.
Precisely.
So checking off our final objectives, what does this all mean for you, the listener? It means that toddlers are not just large infants, and they certainly are not tiny, illogical adults. They are profoundly unique, autonomous explorers. Their bodies are shifting hemodynamically, their vital signs are evolving, and they are experiencing intense cognitive growing pains as their brains try to separate from their parents.
They're trying to map out a world that is much bigger than they are, using neurological tools that are still very much under construction.
Exactly.
We're focusing entirely on Chapter 31, Care of the Family and the Preschool Child.
Exactly. We know you're prepping for the floor, and we're going to make sure you have complete mastery of this material. We're applying a strict clinical lens to the core learning objectives of this chapter. No fluff.
Right. We're going to lock in your age-specific vital signs, contextualize all the key vocabulary so you actually know how to use it at the bedside.
And we'll highlight family-centered and atraumatic care, plus point out those priority pediatric red flags. So let's start with that physical paradox we just mentioned.
Okay, looking at the roadmap, the first major goal of this chapter is assessing normal physical growth. So, Objective 1, assess a preschooler for normal growth and developmental milestones. And Objective 4, describe normal growth and development as well as common parental concerns.
So what is actually happening to the preschooler's body?
Well, the physical transformation is quite stark when you really look closely, even if the scale isn't moving much. That prominent lordosis, the sway back and the protuberant abdomen of the toddler years, they disappear.
And they lose that wide waddling gait, right?
Exactly. They become slimmer, taller, and their proportions look much more childlike than baby-like. But here is the kicker. Their growth actually slows down to about 2 to 3.5 inches and only about 4.5 pounds a year.
Wow, that is a massive deceleration. I imagine parents must panic when their kid suddenly stops eating like a linebacker. I hear parents in the clinic all the time saying, they barely touch their dinner anymore.
Oh, it's a huge source of anxiety. But as the nurse, you provide the anticipatory guidance that this physiological anorexia is completely normal. Their metabolic needs have simply shifted.
Right.
And interestingly, this is the age where you start to see their long-term genetic blueprint taking shape. You'll hear the clinical terms ectomorphic and endomorphic body builds.
Ectomorphic being a naturally slimmer, leaner build, and endomorphic being a larger, broader body build.
Correct. The baby fat melts away, and you can finally see if the child is going to have the ectomorphic build of their mother or, say, the endomorphic build of their grandfather. It's all about establishing that baseline.
Speaking of things that make parents panic, I hear the term genu valgus a lot on the pediatric floor. I know it translates to knock knees, but is that something we actually need to worry about, or is it just an awkward growth phase?
It's exactly that. It's an awkward but entirely physiological growth phase. Parents see their 4-year-old's knees collapsing inward, and they immediately worry about permanent bone deformities or rickets.
But what's actually happening is their center of gravity is shifting, and their skeletal cartilage is growing rapidly to accommodate their new upright posture.
Yes, exactly. Genu valgus almost always resolves on its own with skeletal growth by the end of the preschool period. You can instantly ease a parent's anxiety just by explaining the mechanics behind that assessment finding.
That's a perfect bedside intervention. Now, we have to talk vital signs because pediatrics is deeply age-dependent. You absolutely cannot use adult parameters on a 4-year-old.
Absolutely critical. The preschooler's vital signs shift significantly from the toddler phase. Their resting pulse rate drops to about 85 beats per minute.
Okay, 85 for the pulse.
And their blood pressure holds steady at around 100 over 60 millimeters of mercury.
Got it, 100 over 60 for the BP. But what about when we're actually auscultating? The chapter mentions something very specific about heart murmurs at this age.
Yeah, and the mechanics behind this are fascinating. Their chest wall continues to grow, which alters the anteroposterior and transverse diameters. Basically, the shape of the rib cage is changing.
So because the size of the heart is changing in relation to the thorax, the heart is suddenly sitting slightly differently in the chest cavity.
Exactly. This slight shift creates mild blood flow turbulence that you can actually hear.
Oh, wow. So hearing an innocent physiologic heart murmur at age 4 isn't an instant panic button. It's often just the acoustics of a changing chest cavity.
Right, it's a finding to document and monitor, but frequently it's just physiological.
Well, let's talk about what should cause panic. We need to establish our pediatric red flags. The sources note that preschoolers typically get like 6 to 12 respiratory infections a year. That sounds like a lot of sickness to manage.
It is. They are constantly exposed to new germs at preschool or daycare. But we have to look at what's happening internally. Their lymphatic tissue, particularly the tonsils and adenoids, begins to enlarge significantly.
At the same time, their localized immune system is maturing, right? Their levels of IgE and IgA antibodies are rapidly increasing.
Yes. So if I'm visualizing this, their immune system is like a newly upgraded firewall on a computer network.
I love that analogy. It's getting really good at catching the malware right at the port of entry, the nose and throat, and keeping it localized. They get a stuffy nose, a localized cough, maybe a slightly warm forehead, but they're still running around playing.
That's a great way to look at it. The enlarged tonsils are basically the firewall doing its job, trapping the bacteria or virus. But here's the clinical red flag. What happens when that firewall is breached?
Right. If the localized defenses fail, the alarms need to go off.
Exactly. If you have a preschooler presenting with a high, sudden systemic fever, and you see subtle signs of rapid respiratory decompensation, we're talking about grunting on exhalation, nasal flaring, or retractions where the skin physically pulls in around their ribs.
You must intervene immediately. This is your nurse-first priority action.
Yes.
Let's break down why those specific signs are so dangerous. What is actually happening during a grunt?
Grunting isn't just a noise of discomfort, it's a mechanical rescue attempt by the child's body. They're forcibly trying to keep their alveoli, those tiny air sacs in the lungs, open by exhaling against a partially closed glottis.
Wow. It creates back pressure to prevent lung collapse.
Exactly. And retractions mean they're using accessory muscles because their diaphragm alone isn't pulling in enough oxygen. When a preschooler's localized defenses are breached, they don't have the physiological reserves of an adult. They can and will crash incredibly fast.
Firewall breached, respiratory distress signs appear, immediate intervention required. That is highly testable material. Now, this incredible deceleration in physical growth makes sense when you realize how many calories and how much metabolic energy their body is suddenly diverting to their brain.
Which brings us to Objective 5. Implement nursing care related to normal growth and development of a preschooler, such as preparing a preschooler for an invasive procedure.
Let's transition to that cognitive explosion and how it dictates our traumatic care.
According to Piaget, preschoolers are transitioning into a phase called intuitional thought. They're shifting away from the purely magical, fantasy-based beliefs of the toddler years and starting to try and use rational logic to explain the world.
Which completely explains the endless questions. This is the infamous why phase. They ask up to 400 questions a day. Why is the sky blue? How come I have to wear shoes? Where does the sun go at night?
Yeah, they are desperate to map out cause and effect, but their logic is entirely filtered through what we call egocentrism.
And we need to be very clear here. Egocentrism, in a clinical developmental sense, does not mean the child is selfish or spoiled.
Not at all. It means they literally perceive the world and define objects entirely in relation to themselves. They are incapable of taking another person's perspective.
Can you give a clinical example?
Sure. If you hold up a stethoscope, an older school-age child knows it's an objective medical tool for listening to a heart. An egocentric preschooler thinks, that is the cold thing you put on my chest. The object only exists in how it directly interacts with their own body.
Right. And paired with that egocentrism is their lack of a concept called conservation.
Conservation is the cognitive awareness that altering an object's physical appearance doesn't change its underlying substance or mass.
The classic example is the ball of clay. If I have a round ball of clay and right in front of a preschooler I squash it flat like a pancake, I still have the exact same amount of clay.
But the preschooler doesn't get that. Because it looks wider, they genuinely believe there is now more clay.
Exactly. So let's connect this lack of conservation directly to the bedside for family-centered, atraumatic care. This is paramount.
Imagine a child needs a complicated dressing change. Yesterday, the nurse turned the child on their left side, cleaned the wound, and then turned them on their right side to tape it. Today, you are the nurse. You must do it in that exact same sequence.
Because if I do it differently, like if I turn them right, then left, they don't recognize it.
Right. Because they lack conservation, changing the sequence changes the entire event in their mind. They do not understand it's the same procedure just done in reverse.
To them, it's a completely new, unpredictable, and therefore terrifying procedure.
You've just destroyed whatever trust and routine the previous nurse built.
Okay, wait, you're losing me here. I have to push back on this. If turning a kid on their left side instead of their right makes them think it's a completely new, terrifying procedure, how on earth do we ever get an IV in them? Or do a blood draw?
That's a fair point.
If they're so egocentric and every little change alters their reality, it sounds like literally everything we do in a hospital would traumatize them.
How do you successfully get them to cooperate with a scary, invasive procedure?
Well, you don't force compliance. You guide their imagination. That's the true art of pediatric nursing. You have to leverage their specific developmental stage. You use their active imagination and their drive for initiative.
Give me an example.
If you need to use a stethoscope, don't just walk up and place it on them. Hand it to them first. Let them play with the equipment. Let them listen to their own heart, or better yet, let them listen to their teddy bear's heart.
Ah, so you bring it into their egocentric world first. Precisely. They are master imitators at this age. If you model the behavior you want to see on a doll or a stuffed animal, they're highly likely to imitate that behavior for you. You demystify the equipment by turning it into a tool of play before it becomes a tool of medicine.
That makes so much sense. Use the imagination as a bridge, not an obstacle, which actually leads perfectly into their emotional development and family dynamics. Let's look at objectives 2, 3, and 6. Formulating diagnoses and evaluating effectiveness of care during transitions.
Right. Erikson states the core emotional task of the preschooler is initiative versus guilt. Preschoolers have finally developed the motor skills to initiate tasks on their own. They want to pour their own juice, tie their own shoes, build the block tower.
They need to explore through messy play, like finger painting or playing with clay, to build confidence in their own initiative.
But because their motor skills aren't perfect, they spill the juice. They tie the knot wrong. And this is where the nursing guidance comes in.
Right, if a parent constantly criticizes them for spilling the juice or punishes them for trying and failing, the child internalizes that.
They develop a profound sense of guilt regarding their own independence. That guilt can crush their curiosity and follow them right into the school-age years. We teach parents to praise the effort, not just the outcome.
And navigating family dynamics at this age also brings up two very famous, sometimes uncomfortable concepts from Freud, the Oedipus complex for boys and the Electra complex for girls.
This is where children show a very strong, almost romantic emotional attachment to the parent of a different gender. A 4-year-old boy might declare he's going to marry his mother and actively try to push his father out of the room.
Or a little girl might get fiercely jealous if her mother hugs her father. I can imagine a dad feeling genuinely rejected because his 4-year-old daughter only wants to marry her pediatrician or her mom.
It sounds like an outdated psychological theory, but it happens all the time on the floor. The clinical relevance is very real. The other parent may genuinely feel hurt, jealous, or cut off from the family dynamic.
So the nurse's intervention is vital anticipatory guidance. You sit the parents down and reassure them that this romantic competition is an entirely normal, healthy, and temporary part of preschool development.
Normalizing the behavior saves a lot of familial heartache.
Normalizing is such a powerful tool. Let's talk about normalizing their fears. Because of that vivid imagination and intuitional thought, preschoolers have massive, overwhelming fears. Fear of the dark, fear of abandonment, and a very specific, intense fear of mutilation.
The fear of mutilation is fascinating, and if you don't understand it, you will traumatize your pediatric patients. A preschooler does not understand internal anatomy. They don't know they have a vascular system or distinct organs.
They essentially view their body as a water balloon filled with blood and guts. So if they get a scraped knee on the playground, or you have to do a tiny IV stick,
They genuinely, deeply fear that all of their insides are going to leak out of that tiny hole until they literally deflate. It is a sheer existential panic over a drop of blood.
So how do we provide atraumatic care for a child who thinks they are deflating?
Bandages. A simple Band-Aid. To an adult, a bandage is for infection control. To a preschooler, a bandage is a magical, impenetrable seal that keeps their insides safely inside.
Wow. So putting a brightly colored bandage on a tiny prick provides profound, instantaneous psychological comfort.
It is emotional first aid just as much as physical first aid. Never underestimate the power of a Paw Patrol Band-Aid.
That is incredible. And what about the fear of abandonment? Say a parent is dropping their child off for surgery or even just at daycare and they say, "Don't worry, honey, I'll be back at 3 p.m."
Saying 3 p.m. is utterly meaningless to a preschooler because they have no cognitive concept of clock time. Time is an abstract construct they haven't mastered yet.
So the atraumatic intervention is to translate time into something they do understand, their daily routine.
Exactly. You teach the parents to anchor their return to an event. I will be back right after your afternoon snack, or I will be back after you wake up from your nap. That gives the child a concrete, predictable milestone to hold on to.
It's amazing how this magical thinking is such a double-edged sword. I mean, it creates these wonderful imaginary friends, which the literature says are completely normal and help them practice social skills.
True, but it also means that a friendly pile of laundry on the chair can literally morph into a terrifying monster when the lights go out.
Right. Sleep fears and nightmares peak during this age, and the expert intervention is wonderfully simple and effective. Leave a dim nightlight on.
Because if they wake up terrified from a nightmare, a pitch-black room reinforces the magical thinking. A dim light source immediately grounds them back in physical reality and breaks the illusion that the dark is hiding monsters.
Simple, practical, evidence-based. I love it. All right, we need to cover some common clinical concerns and pediatric red flags related to speech and toileting. Let's look at objectives 7 and 8, integrating QSEN and family nursing.
Let's go back to that analogy of the over-revving engine where the transmission hasn't caught up. This perfectly explains our next clinical term, broken fluency, also known as secondary stuttering.
This is a classic presentation. A preschooler suddenly starts repeating syllables, saying things like, "I want the red toy." Parents often panic, thinking it's a permanent speech impediment or a neurological issue.
But it's actually just their brain working faster than their mouth, right? Their cognitive engine is generating explosive amounts of vocabulary and complex sentence structures, but the physical transmission, the fine motor coordination of their tongue, lips, and vocal cords simply hasn't caught up yet.
So what is the clinical relevance for the nurse? How do we advise the parents?
You must teach parents absolutely not to draw attention to it. Do not tell the child to slow down, take a breath, or punish them. Drawing attention to it makes the child hyper-aware and anxious,
Which increases muscle tension and actually compounds the stuttering, potentially turning a temporary developmental phase into a chronic issue.
Exactly. The intervention is simply to listen patiently and give them time to finish their thought.
Next on the list of concerns is bruxism, or teeth grinding.
Now, occasional grinding, especially at night, can just be a self-soothing habit, similar to rocking or thumb-sucking. But the red flag here is severe aggressive bruxism.
If a child is grinding their teeth down, it is a clinical indicator for the nurse to assess further. It can point to high environmental anxiety, maybe a divorce, or a new baby in the home.
But neurologically, severe bruxism can also be an early indicator of conditions like the spasticity associated with cerebral palsy. It warrants a deeper assessment.
Let's talk about some other pediatric red flags that disguise themselves as behavioral issues but are actually medical emergencies. The chapter specifically highlights pseudo-vomiting.
Pseudo-vomiting is when a child intentionally gags themselves or makes themselves throw up. It is almost always a tactic to avoid separation, like being dropped off at a new preschool. It looks exactly like a behavioral tantrum.
But the danger isn't the behavior, it's the physiology.
Correct. The red flag is the physiologic consequence of the action. A child's fluid volume is incredibly small compared to an adult's. Frequent vomiting in a young child, regardless of whether it is caused by a virus or behavioral pseudo-vomiting, can rapidly lead to severe fluid depletion.
And metabolic alkalosis. It's an electrolyte emergency requiring immediate medical intervention and rehydration, not just a behavioral timeout.
We also need to look at enuresis, or bedwetting. Occasional enuresis is totally normal at this age. They get deeply absorbed in play and ignore the urge to go, or they sleep so deeply they don't wake up.
But the clinical red flag is persistent bedwetting. Especially if the child had previously been potty trained, accompanied by a low-grade fever, abdominal pain, or a sudden urgency to void.
Because that combination of symptoms points away from a behavioral regression and directly toward an infection. That is a primary indicator of a urinary tract infection, or UTI, in a preschooler.
It requires the nurse to obtain a urine culture immediately.
Yeah.
You always rule out the physiological before addressing the behavioral. To wrap up our comprehensive review, we need to integrate our quality and safety education for nurses, or QSEN competencies.
Specifically, aligning with healthy people 2030 goals. Safety is paramount at this age because they are so mobile but completely lack impulse control.
Why is the preschool age specifically the time we heavily focus on bicycle helmets?
Because their gross motor skills have finally advanced enough to allow them to pedal a tricycle or a small bicycle with training wheels. This exposes them to entirely new kinetic risks. Plus, developmentally, their heads are still proportionally larger and heavier than the rest of their body compared to an adult.
Meaning if they fall over, the head acts like a pendulum and often takes the impact first. Mandating helmet use is a major Healthy People 2030 goal to drastically reduce traumatic brain injuries.
And regarding motor vehicle safety, they must remain in booster seats in the back seat until they outgrow them, which is typically around 40 pounds.
Can you explain the why behind the booster seat?
Without a booster seat elevating the child, a standard vehicle seatbelt rests across their soft abdomen and their neck, rather than their hips and collarbone. In a crash, a seatbelt resting on the abdomen will cause catastrophic internal organ damage.
The booster seat literally boosts them up, so the safety restraints engage with their skeletal frame, not their soft tissue. That makes the anticipatory guidance so much more impactful when you actually explain the anatomy behind the rule.
We also need to mention vaccinations, reinforcing the schedule for DTaC, that's diphtheria, tetanus, anacellular pertussis, and the MMR vaccine, measles, mumps, and rubella.
Because they're entering communal settings like preschool, ensuring herd immunity is critical to prevent outbreaks of highly contagious, potentially fatal respiratory and systemic illnesses.
Finally, a very sensitive but crucial QDEN topic, teaching good touch versus bad touch. This is essential anticipatory guidance for preventing sexual maltreatment.
Children need to know their bodies belong entirely to them, and they have the right to say no. But as a pediatric nurse, teaching this isn't just about what you say to the parents. It is about how you model it at the bedside.
How does the nurse model that during care?
Quality, safe care means you always ask the child's permission before performing an invasive procedure. Even something as routine as listening to their lungs, but especially for procedures like a urinary catheterization.
You tell them exactly what you are doing, you explain why you are doing it, and you ensure they understand it is a safe, necessary medical touch. You respect their bodily autonomy.
Wow, we did it! I want to congratulate you, the listener. We have successfully mapped out the entirety of Chapter 31. We covered the paradox of their physical growth versus their cognitive explosion.
We hit all the key vocabulary terms from ectomorphic builds and egocentrism to bruxism and pseudo-vomiting, complete with the clinical why behind them.
We distinguished the distinct preschooler vital signs, locked in the pediatric respiratory and UTI red flags, and thoroughly outlined the traumatic care standards. You are more than ready for this unit exam.
You truly have the tools now to not just pass a multiple-choice test, but to understand the complex, imaginative, and rapidly developing child sitting in front of you.
But before we go, I want to leave you with one final provocative thought to mull over. We spent a lot of time today talking about how a preschooler's brain runs on the operating system of magical thinking and how their core developmental task is establishing a sense of initiative.
Because they are at this exact highly sensitive, highly absorbent developmental stage, your bedside manner during a 4-year-old's hospital admission does so much more than just heal a fatal illness.
Exactly. If you use atraumatic care, if you respect their autonomy, if you take the time to explain the stethoscope, if you provide that magical Band-Aid to soothe their existential fears, you make them feel safe, brave, and capable.
You might just be instilling a lifelong sense of initiative.
Could the way you hand a terrified 4-year-old a Band-Aid today be the exact magical moment that inspires them to become a nurse tomorrow? Think about the lasting impact of your care next time you step onto the pediatric unit.
We're looking at the school-age child, so kids between 6 and 12 years old, and we're extracting the exact clinical insights you need to conquer your pediatric exam.
And just to be clear, our mission for this deep dive is absolute mastery of Chapter 32, care of a family with a school-aged child. We are going to serve as your guides through the source material, systematically conquering every single learning objective and key definition. But we aren't just reciting textbook facts. We are processing all of this through a strict pediatric clinical lens. We're exploring how this developmental knowledge dictates your literal actions at the bedside.
Okay, let's unpack this. We have our mandatory checklist, which is the learning objective, so I'm just going to state them right out loud. Let's start with learning objective 1. Assess a school-age child for normal growth and developmental milestones. And learning objective 4, describe normal growth patterns and common parental concerns.
Perfect. So that age bracket, 6 to 12, it's a fascinating window. It lacks the explosive, visible growth of infancy or the rapid transformation of adolescence.
Yeah, it's much more subtle, right?
Exactly. This period is characterized by slow, steady physical maturation. I mean, they only gain about 3 to 5 pounds and grow roughly 1 to 2 inches per year.
Which kind of lulls parents into thinking nothing major is happening.
It does. But internally, massive physiological shifts are taking place, and this completely alters their vital signs. For this specific age group, the pulse rate actually drops down to 70 to 80 beats per minute, while their blood pressure steadily rises to about 112/60.
See, the numbers change, but as a nurse, you really need to understand the mechanism behind that shift. Like, why is a 70-beat resting pulse suddenly the new normal for them?
Well, it comes down to cardiac and respiratory maturation. The left ventricle of the heart is physically enlarging. Because it's larger and stronger, the stroke volume increases.
Meaning it pumps more blood with every single beat.
Exactly.
Yeah.
The heart simply doesn't have to work as frantically to maintain cardiac output for a larger body mass. And at the same time, the alveoli in their lungs are maturing, which drastically increases their oxygen and carbon dioxide exchange.
Oh.
They're literally building more stamina.
So it's an efficiency upgrade, which means if you are at the bedside and you see a resting pulse of 110 in a healthy 10-year-old, you aren't just looking at a quote-unquote high normal.
No, absolutely not.
Immediately that is outside the developmental parameter, and something else is stressing that child's system.
Right. You have to contextualize the vitals to the developmental stage, or you'll completely miss early signs of decompensation.
I want to look at their behavioral milestones, too, because the changes year by year are wild. A 6-year-old is essentially in a state of constant motion, like they just can't sit still.
Oh yeah, pure energy.
But then they turn 7, and the sources refer to it as the eraser year. Looking at the cognitive leaps of a 7-year-old, how do you explain that to anxious parents?
Well, it almost feels like they're trying to paint a masterpiece, but their hands are wearing thick winter gloves.
Oh, that's a great analogy.
Yeah, their brain sees the vision, but their fine motor skills can't execute it, so they just constantly erase their work until there's a literal hole in the paper. It's a quiet, highly introspective year.
Because they're suddenly aware of their own shortcomings.
Precisely. Their cognitive standards have outpaced their physical abilities. They strive for perfection and inevitably fall short. But then, by age 9, they shift into this intense club-forming phase. Secret codes, strict rules, heavy socialization.
And then by 12, they are suddenly capable of carrying on a nuanced adult conversation. It's quite the spectrum.
It really is.
I was reading about the immune system shifts during this time, specifically how immunoglobulin G and A reach adult levels. It leads to this explosion of lymphatic tissue to the point where their tonsils look absolutely huge, taking up the whole back of the throat.
Yep, very common assessment finding.
But what caught me off guard in the reading was how this connects to appendicitis. How does abundant lymphatic tissue make a kid more susceptible to a ruptured appendix?
So this is a huge pediatric red flag. The tonsils aren't the only place where lymphatic tissue is growing rapidly.
Right.
The appendix itself is lined with this exact same tissue.
Oh, wow.
Yeah. Remember, the appendix is just a narrow, blind-ended tube attached to the cecum. If that lymphatic lining swells up, even just from a mild viral infection, it narrows the tube even further.
Creating a bottleneck.
Exactly. Fecal material easily gets trapped in that bottleneck. It hardens, cuts off the blood supply, and leads to rapid inflammation. Because the tube is so small to begin with in a school-aged child, it can rupture very quickly.
That changes how you look at a simple stomachache entirely. You can't just assume it's a GI bug.
Never. If a school-aged child presents with severe abdominal pain, your nurse's first priority action is to rule out rapid decompensation from appendicitis immediately. You don't wait to see if it passes.
Got it. There's a weird diagnostic quirk with headaches, too, involving the frontal sinuses.
Yes. The frontal sinuses, the ones right above the eyes, do not fully develop until around age 6.
Okay, so what's the clinical takeaway there?
The takeaway is chronological. If a child who is 4 or 5 presents with a severe frontal headache, it is rarely a simple sinus infection because there literally isn't enough sinus cavity there to get infected.
Sorry. A headache in a preschooler warrants priority investigation to rule out more serious neurological or systemic issues. But once they hit our 6 to 12 school-aged bracket, those cavities are developed. So sinus headaches officially become a valid possibility on your differential diagnosis list.
Exactly.
Okay, so their bodies are growing slowly but steadily, their immune systems are remodeling, but internally, their brains are going through an absolute revolution. Let's hit the next objectives. Learning Objective 5, implement nursing care to promote normal growth and development, including counseling parents. And Learning Objective 8, integrate knowledge of growth and development with the nursing process and family nursing.
Let's do it. So this internal revolution is what Piaget defined as the transition to concrete operational thought. They can finally reason through problems, but only if they can visualize them.
Right. They are moving away from the magical thinking of a toddler. And the sources gave us 3 crucial vocabulary concepts here that change everything about how a nurse interacts with them.
Yes, starting with accommodation, which is the ability to adapt thought processes to fit what is perceived.
How does that look on the floor?
Well, a preschooler expects the exact same nurse they had yesterday to walk through the door, and they might cry if someone else appears. But a school-aged child can actually accommodate the complex concept that a hospital runs 24/7, and nurses work in shifts.
That makes sense. The second concept is conservation, which is the understanding that a change in shape doesn't mean a change in size or volume. And this totally changes medication administration at the bedside.
Oh, absolutely it does.
Because you can't trick an 8-year-old like you can a toddler. You can't take 30 ml of nasty-tasting medicine in a tall, thin cup and pour it into a short, wide cup to make it look like less.
They know it's the exact same amount, and if you try to pull that trick, you immediately lose their trust. And traumatic care for this age group relies heavily on honesty.
Right. And the third cognitive leap is class inclusion, understanding that objects can belong to more than one category at the same time. Like, a toy car is a car, but it's also a vehicle and it's also a metal object.
Which perfectly explains why 8- and 9-year-olds are absolutely obsessed with collecting and sorting things.
Right.
Trading cards, rocks, action figures.
It's not just a hobby, right?
No, it's them exercising a new cognitive muscle.
Yeah.
It is the fundamental cognitive foundation for learning complex math and reading comprehension.
Okay, so layering onto that cognitive shift is their psychosocial development. Erikson calls this phase industry versus inferiority. They are desperate to learn how to do things and, more importantly, how to do them well. They want to produce something.
Which is a golden opportunity for the bedside nurse. You can use that drive for industry to provide atraumatic care by giving them short-term, achievable projects regarding their own health.
Give me an example of that.
So if you have a newly diagnosed 9-year-old diabetic, you don't just check their blood sugar for them. You teach them how to do it. You give them a logbook, you let them chart the numbers themselves, and you praise their accuracy.
Okay, here's where it gets really interesting. That sounds great in theory, but hospital units are absolute chaos.
Sure.
If a 10-year-old is cognitively obsessed with strict rules and absolute fairness, how on earth do you explain why the toddler in the next room gets to break the playroom rules? Or why another patient gets to avoid certain unpleasant procedures without triggering a massive meltdown over things being unfair?
It's a great point because navigating that developmental contradiction is tricky. The 10-year-old expects rigid conformity. The way you handle it is through clear, highly logical communication.
So you don't just default to because they are younger or because I said so.
Exactly. You leverage their new ability to understand cause and effect. You explain that different bodies need entirely different types of care to heal. You frame the modified rules for the toddler as an individualized medical necessity, much like a prescription, rather than an arbitrary waiving of the rules.
Oh, I like that.
It validates their need for logic while simultaneously teaching them clinical empathy.
That makes perfect sense. You give them the why. Now, another major shift disrupting their sense of order and rules is puberty. And the timeline for physical and sexual development is incredibly variable.
It is. We track it using Tanner stages. For females, sexual maturation usually occurs anywhere between 12 and 18 years of age. For males, it's typically between 14 and 20. But the onset is happening earlier and earlier.
And the key vocabulary concept here regarding male development is nocturnal emission. Basically ejaculation during sleep, which happens as the body's production of seminal fluid naturally increases.
Yes, and the clinical relevance here isn't just knowing the definition, It's proactive education.
Because if they don't know it's coming.
Exactly. Males who are not prepared for this entirely normal physical change can experience intense worry, guilt, or shame, thinking something is medically wrong with them. Nurses must prompt parents to have these conversations early, before the physiological changes begin.
And that anxiety applies to female development, too. I mean, how do you reassure a preteen girl whose breasts are developing asymmetrically? Or a boy experiencing gynecomastia, which is breast hypertrophy?
It's sensitive.
Yeah, when a kid comes in panicked about their changing body, how do you reassure them without sounding dismissive of their very real fear?
Atraumatic communication in these moments requires giving them the physiological mechanism to conquer their psychological fear. For the preteen female, you first conduct a thorough, respectful physical exam. You don't just brush it off.
Right, you validate them.
Once you confirm it is normal, you logically explain that breast development is rarely perfectly symmetrical at the start. One side usually responds to hormones faster than the other.
And for the boys.
For the male experiencing gynecomastia, which is incredibly common, especially related to minor weight fluctuations, you explain the hormonal mechanics. You assure them that it is a transitory phenomenon. It will naturally decrease as male hormones rise during maturation.
So you give them the physiological why to alleviate the psychological what if.
Exactly.
Speaking of psychological health, the sources also looked at transgender children in this specific 3 to 12 age bracket. So children whose gender identity does not match their sex assigned at birth.
Yes.
And we are just reporting what the source material states here, but the data showed that when these kids have strong family support, their depression rates matched their cisgender peers.
That's right. The studies show they might have slightly higher anxiety scores, but importantly not in the preclinical or clinical range.
So what's the clinical takeaway for the nurse?
It's profound, actually. It means that family-centered support acts as a literal, measurable protective factor against severe psychological distress. The nurse's role isn't just treating a physical ailment, it's modeling affirming, inclusive care and guiding families toward resources that build that supportive environment.
It reinforces that you are treating the whole family unit.
Always.
Okay, I want to pivot to something incredibly common but often overlooked, which brings us to our final set of objectives. Learning Objective 2, formulate nursing diagnoses. Learning Objective 3, establish expected outcomes. Learning Objective 6, evaluate outcomes. And Learning Objective 7, plan care using QSEN competencies like safety and teamwork.
That's a lot, but they all tie together perfectly in the clinical setting.
They do. And starting with dental health, I noticed that caries, which is literally the decavitation of tooth enamel or cavities, are listed as the #1 health problem for this age group. Why this specific window?
Well, it's the perfect storm. They are losing their deciduous, or primary teeth, and gaining their permanent teeth. Their diet often becomes more independent, meaning more unsupervised access to sugar.
Yeah, I remember that phase.
But crucially, while they have the independence to brush their own teeth, they often lack the executive function and find motor patients to do it thoroughly without parental supervision.
Right.
Combine that with malocclusion, which is a deviation of normal tooth position that often requires orthodontic braces or retainers, and you have a high-risk environment for enamel decay.
And if you are a nurse clearing a hospital food tray for a kid with one of those retainers, you have to check the napkins.
Oh, yes.
Because kids routinely take the retainers out to eat and hide them in folded napkins on the tray. It is the easiest way to accidentally throw a $1,000 orthodontic device straight into the biohazard bin.
It happens far more often than you'd think. Always check the tray.
Let's talk about safety outside the hospital, leaning into those QSEN competencies. The sources spend significant time on latchkey kids. You know, children who spend time at home unsupervised after school while parents are still at work.
The safety implications for latchkey kids require serious nursing intervention during discharge planning or routine physicals. Nurses have to help families create concrete care maps for that independent time.
What does that look like in practice?
This includes establishing strict internet and social media safety rules to prevent online exploitation, because this is the age they start exploring the digital world independently. But it also involves physical security. A core recommendation is setting up a secret code word.
Like a password just for the family.
Exactly. The child is taught never to open the front door or leave school with anyone, even a neighbor or a distant relative, who doesn't know that specific code word. It's a direct, tangible intervention to prevent abduction or sexual maltreatment.
It's fascinating how much of their well-being is tied to their environment and psychological state, which brings me to one of the red flags that really caught my attention. how their bodies convert psychological stress into physical symptoms, like blood ticks.
Yes.
But how do you tell a tick from a seizure? Because if a first grader under stress starts blinking constantly or clearing their throat, a parent's first thought is going to be a neurological event.
It's all about observing the nervous system's behavior during different states of consciousness. Tics are irregular, repetitive movements of isolated muscle groups. They are intrinsically linked to psychological stress.
So if the child is anxious, the nights get worse.
Right. But crucially, they will completely disappear during sleep. Seizures do not respect sleep cycles. If the repetitive movements stop the second the child falls asleep, the nurse must assess for underlying psychosocial stressors, rather than immediately jumping to an invasive epilepsy workup.
Wow. And that mind-body connection goes beyond isolated muscle movements. I'm thinking about the kids who physically vomit before the school bus arrives.
Yeah, that is school refusal.
Right.
It often presents as vomiting, severe stomach aches, or headaches that miraculously resolve 10 minutes after the school bus leaves without them.
But they aren't faking it, right?
No, the physical symptoms are very real to the child. They aren't faking the nausea, but the etiology is psychological. It's a manifestation of social phobia or separation anxiety. The priority nursing assessment isn't just ordering a GI panel. It's sitting down and asking the hard questions about severe bullying, an abusive teacher, or intense academic pressure.
The final red flag in the material scared me a bit, honestly. It involves recreational drug use, but not the kind you typically think of for teenagers. We're talking about inhalants.
Yes, school-age children, particularly toward the 10 to 12 range, may experiment with highly accessible household inhalants. Things like airplane glue, aerosol cooking spray, or a computer duster.
Just stuff lying around the house.
Exactly. They sniff the fumes for a brief feeling of giddiness or euphoria.
But the hidden danger here is massive.
It's lethal. High concentrations of these chemical fumes cause immediate massive liver damage. More urgently, it damages the alveoli we talked about earlier, leading to impending pulmonary edema. Their lungs start filling with fluid.
So if you have a school-aged kid who comes into the clinic or the ER appearing inexplicably drowsy, irritable, or giddy, and they start showing subtle signs of respiratory distress like grunting, nasal flaring, or retractions between their ribs.
That requires immediate, life-saving nurse first intervention. You do not wait to see if they perk up. You must secure their airway, provide immediate oxygenation, and prepare the team for rapid decompensation related to inhalant abuse and pulmonary edema.
We have covered an incredible amount of ground today. To the nursing student listening to this right now, you have just systematically conquered the core of pediatric care for the school-age child.
You really have.
We've mapped out the physical milestones, like the dropping heart rate and the tonsillar hypertrophy. We've navigated the cognitive leaps of accommodation and conservation, tackled the onset of puberty, and flagged the critical dangers from appendicitis to inhalant abuse. You have the clinical context for all of it.
So what does this all mean? If we step back and look at the bigger picture, mastering this material isn't just about passing a multiple choice exam. It's about equipping yourself to become a nurse who sees the whole patient.
Right.
You aren't just treating a fractured arm or a viral infection. You are treating a rapidly developing human mind and body that interacts dynamically with its environment.
Exactly. Now, I want to leave you with one final puzzle to mull over on your own as you continue studying. We've learned today that school-age children desperately crave a sense of industry. They need to feel they can accomplish tasks, they want to create things, and they thrive on strict rules and daily routines. So I want you to think about this. What happens to a 9-year-old's psychological development when a chaotic, unpredictable chronic illness completely strips away their ability to attend school, see their friends, or finish a project? How will you, as their bedside nurse, step in and redefine their world so they can still feel a sense of accomplishment and mastery while confined to a hospital bed?
Today we're taking on Chapter 33, Growth and Development of an Adolescent. But before we even look at the pathology or the psychosocial theories, we really need a physical baseline. When you walk into that adolescent patient's room, what should those monitors be telling you?
Well, setting that baseline is the absolute critical first step because in pediatrics, every single thing is age dependent. We define adolescence as the period between 13 and 20 years old.
Right.
And during this specific window, you see a major developmental shift in their vital signs. They're moving away from the rapid rates of childhood and getting, much closer to adult parameters.
So what are the specific numbers we're looking for?
So the heart rate drops to about 70 beats per minute.
Okay, 70.
Yeah, and the respiratory rate settles down to 20 breaths per minute. And then the blood pressure increases slightly to around 120 over 70 millimeters of mercury.
Now, I noticed in the clinical notes that blood pressure tends to be slightly higher in males by late adolescence. Is that like just a hormonal difference?
It's actually a matter of pure physics, really, and body mass.
Right.
By late adolescence, males typically have a significantly larger muscle mass and overall body size than females.
Oh, right. That makes sense.
Yeah, the heart simply has to pump with more force to distribute blood across that larger physical area, which registers as a slightly higher baseline blood pressure. But you have to burn those baselines into your brain.
70 beats, 20 breaths, 120 over 70.
Exactly. Those numbers are your anchor. They're exactly how you'll recognize when a 15-year-old patient is quietly decompensating.
With that vital signs baseline locked in, let's look at our first set of mandates. Our roadmap says we need to conquer Objective 2, which is to assess an adolescent for normal growth and development milestones.
It's a huge topic.
Yeah, and we're pairing that with Objective 5, describe normal growth and development and common parental concerns, and Objective 1, identify healthy people, 2030 goals related to adolescence. So how do we clinically define this massive growth spurt?
This is where we need to be very precise with our terminology. The term adolescence refers to the broader transition period from 13 to 20 years old. But clinically speaking, adolescence is defined much less by their chronologic age and much more by their physiologic and psychological changes.
It's an era of transition.
Exactly.
Right, which brings us to the physical trigger for all of this, puberty. The clinical definition of puberty is the exact time an individual first becomes capable of sexual reproduction. For females, we mark that capability by menstruation or menarche. For males, it's marked by the production of spermatozoa. And when you're doing your physical assessment at the bedside, you track this physical progression using Tanner stages.
Which is that standardized clinical scale from 1 to 5, right?
Yep. It measures those physical puberty markers.
And you'll see that those physical growth milestones vary drastically depending on the biological sex of your patient. Females typically experience their massive growth spurt earlier, and they usually stop growing entirely about 3 years after menarche.
And males?
Males, on the other hand, have a delayed but much longer growth trajectory. They might continue to grow until they're 18 to 20 years old, and the gains are staggering.
Oh, staggering. What are you talking?
We're talking about gaining anywhere from 15 to 65 pounds and shooting up 4 to 12 inches in height.
Wow. I mean, I cannot even imagine what it feels like to have your skeleton grow a foot in such a short amount of time. But there's a really dangerous nuance here for the pediatric assessment, isn't there? The whole body isn't growing at the exact same speed.
That is the critical physiological mismatch every pediatric nurse needs to understand. During this massive skeletal and muscular growth spurt, the heart and the lungs actually grow at a much slower rate.
Right. I always picture it like someone taking a standard lawnmower engine and dropping it under the hood of a high-performance sports car.
That is a great analogy.
Yeah, the chassis, the teenager's body, it looks huge and fast and capable. But the internal motor, the cardiopulmonary system, hasn't caught up to the new size yet. How does that specific lag actually look when you're treating them?
It looks like sudden, intense, almost inexplicable fatigue. You'll have a 15-year-old who just grew 6 inches, and when they try to finish a cardiovascular activity, like running a drill at soccer practice or even just climbing a few flights of stairs, they literally run out of cardiopulmonary reserve.
Oh, wow.
Yeah, their slower-growing heart and lungs simply cannot pump enough oxygen to keep up with the metabolic demands of their newly enlarged musculoskeletal system.
I imagine parents must get incredibly frustrated by that. They see a young adult who looks strong, but is suddenly constantly exhausted.
They do. Parents misinterpret this biological limitation all the time. They call it laziness. They think the teen is just, unmotivated or acting out.
Which is so unfair to the teen.
Exactly. And this is where your role in family-centered care becomes so vital. As the nurse, you have to educate the family. You have to sit them down and explain the physiology. You tell them your child is not lazy. Their organs are literally trying to catch up to their bones.
I bet removing that blame drastically reduces the friction in the household.
Oh, absolutely. It's a game changer.
Which is a perfect pivot to Objective 1, identifying the healthy people 2030 goals. Because if we're looking at the health of the nation, the objectives are heavily focused on this exact age group. The clinical logic is that habits formed during this chaotic window are going to dictate their adult health.
Exactly. The government and clinical bodies look at the data and they set very specific targets. The major targets for adolescents include managing and reducing childhood obesity down to a goal of 15.5%.
Okay, 15.5%.
Right. They also want to increase private preventative healthcare visits. And that word private is key, meaning the teen speaks to the healthcare provider without the parent in the room.
That autonomy is so important.
It really is. And finally, significantly reducing high-risk behaviors like smoking tobacco and carrying weapons like guns.
I know the last point can feel like a heavy, almost societal issue rather than a nursing one, but we have to approach it strictly through our clinical lens. The data is clear. Access to firearms is a leading risk factor for adolescent homicides and suicides.
Very true.
And the vast majority of lifelong tobacco use begins right now in adolescence. So our nursing care plans have to incorporate objective, routine screening and education on these exact risks.
We cannot let our own discomfort stop us from asking the safety questions. It's a standard part of the pediatric assessment.
Now, let's talk about a physical change that causes an entirely different kind of distress. All those rising hormones driving that massive growth spurt are not just affecting the bones, they're throwing the sebaceous glands into overdrive. And that brings us to the clinical term, comedones.
Yes, comedones are what we commonly call whiteheads or blackheads. The rising androgen levels stimulate the sebaceous glands to produce excess sebum, which then gets trapped in the hair follicles.
So from a family-centered care perspective, how do we handle this? Because to a teenager, acne is not just a minor dermatological issue. It can feel like the end of the world.
Oh, it's a profound psychosocial stressor. When you're educating the teen and the parents, you validate that acne is a normal, expected part of development. But you must absolutely stress that they cannot squeeze those comedones.
Right, because of the damage it does.
Exactly. When a teen squeezes a pimple, they often rupture the gland beneath the surface of the skin. That spreads the trapped sebum and bacteria deep into the surrounding tissue, causing a severe, sometimes scarring inflammatory dermal reaction.
And think about this from an atraumatic care perspective. If you have an adolescent admitted to your pediatric unit for a few days, they're already out of their element. Your care plan should actively carve out dedicated, uninterrupted time for their self-care and hygiene routine.
Yes, absolutely.
Let them wash their hair, give them the time and privacy to apply their topical acne treatments. It might seem small, but maintaining their appearance minimizes the profound psychological distress of feeling ugly or exposed while hospitalized.
That physical awkwardness and hyper-awareness of their appearance bridges us perfectly into how they are actually processing the world around them.
Let's follow that bridge right into segment 2, Inside the Adolescent Mind. We're pulling up our checklist to cover Objective 3, formulate nursing diagnoses related to adolescent growth and development, and Objective 4, identify expected outcomes for nursing care, as well as help parents manage seamless transitions.
So to understand the adolescent mind, we rely on two foundational developmental theories. First is Piaget's concept of formal operational thought.
Okay, formal operational thought.
Right. This is a cognitive stage that kicks in around ages 12 or 13. What it means clinically is that the adolescent is no longer bound by concrete right in front of them thinking.
Like a younger child would be.
Exactly. A younger child needs to see the physical blocks to count them. An adolescent with formal operational thought can think in abstract terms. They can use deductive reasoning, they can test hypotheses in their head, and they can project into the future.
Okay, that covers the cognitive side. What about the psychosocial side?
That's where Erikson comes in. Erikson defines the primary developmental task for early and mid-adolescence as identity versus role confusion. Their one overarching job right now is to figure out who they are as an individual, separate from their family.
That's a huge task.
It is. They have to accept their rapidly changing body, start planning a vague career trajectory, and begin emancipating themselves from their parents.
And if they fail to do that?
Then they suffer from role confusion. If they cannot form a stable identity, they become overwhelmed. They cannot handle new clinical or social challenges, which frequently leads to inappropriate acting out.
Wow.
And just to track this to the end of the age bracket, by late adolescence, around 18 to 20, that primary task shifts to intimacy versus isolation, where their focus moves toward forming long-term, meaningful, emotional relationships.
Okay, I have to push back here because this is the part that always confuses people. You just said they have formal operational thought.
Right.
You said they can use deductive reasoning, project into the future, and think abstractly, just like adults. If their brains are that advanced, why do they still make such notoriously terrible, impulsive decisions about their health and safety?
It's the ultimate paradox of pediatric nursing. Yes, they have the hardware to think abstractly about the future, but their internal compass is intensely, overwhelmingly present-oriented.
Ah,
In their daily lives, achieving social acceptance, right? This second heavily outweighs the abstract concept of physical health 10 years from now.
so how does that reality dictate the way we provide atraumatic care and education at the bedside? Because clearly, standard adult education isn't going to work.
It changes everything. Let's say you have a 14-year-old with asthma. If you tell them to take their daily inhaled corticosteroids to prevent airway scarring when they're 30 years old, that education will completely fail.
Because 30 doesn't even feel real to them.
Exactly. To a 14-year-old, being 30 is a lifetime away. It is not a real consequence to them. An atraumatic, patient-centered approach means framing your clinical outcomes around immediate, tangible goals.
So instead of talking about their 30s, you say, using this inhaler every morning is going to keep your lungs clear so you don't get winded, and you can play your absolute best in the basketball game this afternoon.
Precisely. You tie the health intervention to their present moment identity and social goals. You give them choices to respect their autonomy.
And what about their parents?
You ensure privacy. You ask the parents to step out of the room so the teen can be honest with you about their habits without fear of getting grounded. You focus on the now.
That perfectly sets up the crucial nursing diagnosis we need to master for Objective 3. Listeners, write this one down. Situational low self-esteem related to alteration in appearance.
Whether a teen is dealing with severe acne, navigating obesity, or just struggling with the awkwardness of uneven growth spurts, their fragile, developing identity is inextricably tied to how they look.
Right.
If they perceive that they look different from their peers, their self-esteem absolutely plummets.
And when a teenager with plummeting self-esteem is desperate to fit in, they start looking for peer approval through other avenues, which are almost always risky.
Exactly. And that leads us directly into the most dangerous waters of adolescent nursing.
Let's consult the roadmap for Segment 3, high-risk behaviors and immediate priorities. We need to explicitly check off Objective 6, implement nursing care related to special needs, such as preventing substance use disorders. Objective 8, plan care using QSN competencies like safety and teamwork. And Objective 9, integrate knowledge with family nursing.
If we connect this to the bigger picture, everything we've discussed so far, the physical awkwardness, the present-oriented thinking, the desperation for peer identity, you get a patient who is highly vulnerable.
Yeah, perfect storm. Let's define substance use disorder.
Clinically, this is the use of chemicals to intentionally influence mental states or induce euphoria. And the vital takeaway from the research is that alcohol is the primary gateway drug. Its use almost universally precedes the use of tobacco and cannabis in this demographic.
And sometimes the risk-taking isn't even about getting high, right? It's about athletic identity. There's a sports nutrition term in our text called glycogen loading. What exactly is happening in the body here?
Glycogen loading is a practice where an athlete purposefully and completely depletes their muscle glycogen stores through intense exercise and diet, and then intensely carb loads.
Like eating a mountain of pasta.
Exactly. The goal is to force the muscles to store 2 to 3 times the normal amount of glycogen to provide sustained energy during a big game or event.
But why is this a nursing issue? Why do we care if a high school runner eats a ton of pasta?
Because they are doing it to an incomplete, rapidly growing body. When a high school athlete attempts this to gain a competitive edge without strict professional medical monitoring, it can cause severe fluid shifts and metabolic derangements.
Oh, wow. I didn't realize it was that severe.
Yeah, you're messing with the cellular energy storage of a system that is already taxed by massive skeletal growth. It's a prime example of an adolescent risking their physiological safety for immediate athletic and peer approval.
That desire for social connection also opens them up to incredible psychological danger, bringing us to the clinical reality of stalking. In the pediatric context, this involves repetitive, intrusive actions and heavily includes cyberstalking and electronic aggression.
As bedside nurses, we have to actively screen for this. You might have a patient presenting with vague somatic symptoms, stomach aches, headaches, insomnia.
And those could be tied to their online life.
Absolutely. You have to ask about their online life. Being the victim of electronic aggression triggers severe, sometimes life-threatening psychological trauma because there is no escape from it. It follows them into their bedroom via their phone.
And speaking of life-threatening situations, let's talk about QSEN, quality and safety education for nurses. When an adolescent comes into the emergency department or onto your unit with a toxic ingestion, what are the pediatric red flags? What is the absolute priority, nurse-first action when they're rapidly decompensating?
Let's break down the major toxidromes. First, opioids. This includes heroin,
Yeah.
fentanyl, or raiding a parent's prescription painkillers. The cardinal red flag here is respiratory depression.
Right, think back to the baseline we established at the beginning of the episode. Normal is 20 breaths per minute.
Exactly. If you have an adolescent breathing at 8 or 10 breaths per minute, that is a blaring, critical red flag. Your immediate nurse-first action is the administration of naloxone and providing bag valve mask respiratory support.
You don't wait for a doctor.
You do not wait for a physician to assess them. You protect the airway immediately.
Okay, what if the ingestion is cocaine or crack?
These are profound central nervous system stimulants. The mechanisms here are totally different. The red flags are severe tachyarrhythmia, meaning a heart rate wildly above that 70 beats per minute baseline, along with tachypnea or rapid breathing and seizures. The drug is causing massive cardiovascular overload. They are at immediate risk for a lethal cardiac arrest.
And finally, there's a trend we're seeing a lot more of in pediatrics: farming.
Farming is when teens raid the family medicine cabinet or use veterinary drugs, often mixing them at random. For example, they might take methylphenidate, like Ritalin, crush it up, and inject it intravenously.
Which is incredibly dangerous mechanically, not just chemical.
Absolutely. Those pills are full of binders and fillers designed to be digested in the stomach. When you inject them into a vein, those undissolved particles travel right to the lungs and block the pulmonary capillaries, causing multiple pulmonary emboli.
That's terrifying.
It is. Or they might use veterinary ketamine. The red flag with farming is that you are dealing with an entirely unknown toxicology profile. You have to be prepared for unpredictable, sudden respiratory or cardiac failure.
This is where the clinical reality of our job gets very heavy. The darkest intersection of everything we've talked about, the role confusion, the online stalking, the substance use, is the risk of self-harm. Which brings us to our final mandate, segment 4, the ultimate safety priority.
Right.
We're reading Objective 7. Evaluate expected outcomes for achievement and effectiveness of care, specifically focusing on mental health, safety, and depression.
It's a sobering statistic that we all must face. Suicide is the second leading cause of death in this age group. As a pediatric nurse, your assessment skills in this area literally save lives.
You really do.
But the pediatric red flags for rapid psychiatric decompensation and impending suicide are not always what the textbooks make you think. It's not always active crying or obvious visible despair.
Right. The most critical red flags can actually seem like positive changes to an untrained eye. We're looking for sudden, unexplained elevations in mood or the adolescent giving away their prized possessions.
You have to understand the psychology behind those actions. Why a sudden elevation in mood? Because the adolescent, who has been battling severe internal anguish, has finally made the definitive, concrete decision to end their life.
Oh, wow.
Making that decision brings them a temporary, profound sense of relief from their psychological pain. They seem happier because they believe the pain is about to end. And giving away something they love, like a prized baseball card collection or a favorite jacket, to a younger sibling is their way of tying up loose ends.
So if parents report these behaviors, you escalate the situation immediately.
Instantly.
From a clinical relevance and atraumatic care standpoint, we also need to address a suicide gesture. This is a purposefully unsuccessful attempt or a failed attempt. Do not ever dismiss this as just seeking attention. It is a blaring alarm. Your immediate nurse-first action. That patient is never left alone again. You initiate one-to-one observation instantly, and you utilize your QSEN, teamwork, and collaboration competencies to immediately trigger an urgent psychiatric consult.
And managing this requires intense, compassionate, family-centered care. The parents are going to be terrified, confused, and likely feeling guilty. You have to teach parents that an adolescent's developmental need for emancipation does not mean severing the parent-child relationship.
It's just a shift.
Parents need to consciously shift their parenting style. They need to move away from being an authoritarian figure of total control and instead become a supportive safety net. They must allow the teen to have independence while remaining a visible, reliable bedrock of support.
Which is absolutely vital for teens who are feeling isolated, depressed, or adrift in role confusion.
Completely vital.
Well, we have covered an incredible amount of ground today. Looking at our roadmap, we have successfully conquered every single learning objective and key definition for Chapter 33. We started with the physiological mismatch of puberty. navigated the abstract but intensely present-focused adolescent mind, identified the physiological red flags of substance use, and prioritized the subtle, critical signs of depression and self-harm. So, what does this all mean for you at the bedside?
It means that absolute mastery of adolescent nursing requires a very delicate balancing act. You have to respect their autonomy and their developing identity. You have to deeply understand the physiological mismatch of their rapid skeletal growth versus their lagging organ capacity.
Right.
And most importantly, you must maintain absolute high-level vigilance for the subtle, non-traditional signs of both physical decompensation and psychological distress.
I want to leave you with a final, provocative thought to mull over as you prep for your exam. We know from our discussion that adolescents possess formal operational thought. They can think logically and abstractly. Yet their brains are entirely driven by present-moment peer acceptance.
Right, the paradox.
Exactly. If they are literally wired to prioritize social rewards over long-term risks, how might we completely redesign our hospital discharge instructions? Could we actually leverage their peer networks to improve their medication adherence rather than just handing them a sterile piece of paper about long-term risks that we know they're going to ignore?
That is the exact kind of critical thinking that pushes pediatric nursing forward. How do we make the treatment plan feel as socially rewarding and immediate as the risky behaviors they're tempted by?
It is definitely something to think about the next time you're educating a 15-year-old patient. We wish you the absolute best of luck on your upcoming pediatric unit exam.